transplant immunology diagnostics. The first talk is going to be on physical cross-matching in transplantation and practical application. I'd like to invite the chairpersons on stage, Dr. Ashwini Kandekar, Senior Consultant Nephrologist and Transplant Physician from KIMS Kingway Hospital, Nagpur. He's received the H.L. Trivedi Gold Medal for Best Student in DNB Nephrology in 2008. He's a reviewer and member of the editorial board of the Journal of the Nephrology Society. He's a member of the Kidney Committee, ZTCC, Nagpur. And he's the past president of the Nephrology Society. And Dr. Nitin Dayal, Principal Consultant and Head at Max Super Specialty Hospitals, Delhi. He's got multiple publications in various national and international journals. He's an NABL assessor for the field of hematology, clinical pathology, and cytology since 2010. I'd like to request the chairpersons to please introduce the speaker.
Actually, he is the best person to speak upon this topic in whole country right now. Anil?
Thank you.
Stage is yours.
So, good evening, ladies and gentlemen, and thank you for the audience who's still sitting in the hall. More importantly, the talk that I've been assigned is physical cross-matching in transplantation and practical application. So, this is the place where I work in Delhi, and this is how I have designed my talk. I promise you I'll not take more than 15 minutes. And this is about, so we'll have a little bit of a quiz, just a teaser. And then we'll talk about practical applications when we talk about physical cross-matching. I'll not bore you with HLA typing, but I'll give you some insights into the assays that we have today, and finally a summary and a take-home message. Okay, so we start with the quiz, and I want all of you to be, those who are in the hall with me. And I start from here. What's this? Nothing to do with transplants. So this is an old symbol of Twitter, right? And what's this? This is the newer one, the X, wonderful. And this? Instagram, at least the ladies should say. They're all on the Insta, isn't it? And this? Something we can't live without today, right? And then this? Facebook, wonderful. And of course the YouTube. How can we forget all of these? What am I trying to tell you by giving you all this information? All this is what is life today. It's all virtual, and everything seems to be virtual. Nothing seems to be physical, and we're all living in what is called the virtual world. And who would have imagined this maybe about 5-6 years ago? Because COVID actually made us believe that everything virtual is very good. And if I give you a reference of this particular article, just to give you the insights into the virtual world of transplant immunology. And if you go through the entire picture on the left-hand side, you would suddenly start believing that anything that's virtual in the field of transplantation is absolutely perfect. And there's nothing that you should actually be worried about the moment you get into virtual cross-matching and virtual transplantation. Well, if all that was true, then we wouldn't be talking about something called physical. So what I'll do is I'll try to give you insights and the practical applications in the era of virtual cross-matching. Why do I still talk about physical cross-matching? And I'm sure I should be able to tell you in the next 15 minutes why physical cross-matching is still important. So I first start with a study which we did in the 3 transplant centers in Delhi with my colleagues from Medanta and Polo in Delhi. And we looked at the pre-transplant compatibility testing and the algorithm that we developed as a multi-center study. Now, if you look at the testing part of it, and I'll show you here very clearly, the obvious is that when you have a cell-based assay, the CDC actually, as far as sensitivity is concerned, is extremely poor. And this is already published data, right? But the moment you add another cell-based assay to it, which is a flow cross-match, just look at the sensitivity. It suddenly starts going up. So what am I trying to tell you? That there was a physical cross-match where we were looking at the cells and we were looking at the antibody mixing them together. But as an assay, CDC per se had its own challenges. And mind you, this is in CDC with AHG. The moment you added beads to it, and I'm sure all of you would say, oh, solid phase assays, suddenly beautiful. But just look at the sensitivity. Even there, the sensitivities are not reaching 100%. But then the moment you add these combinations of tests, look at what happens to the sensitivity suddenly. It suddenly reaches 100%. So what am I trying to say? All I'm trying to say is each of these tests have their own value, and I'll show you that in my subsequent slides. So this is what we saw, just like any other study which was happening in this field. We also saw that flow cross-match and a bead-based assay at the same time was giving you a much better correlation with the testing part of it. And when we looked at some of these cases, there were still some discordances. What were the discordances? You were not able to have representations of DP and DQ in your assays. So the moment you did not have them, obviously you're not picking up these cases at all, and they would turn out to be negative. And now I'll emphasize this with a case study, a real-life case study, a 39-year-old lady who was ABO matched for end-stage renal disease, no prior transfusion, and mother was the prospective donor. She was a haplomatch, 6/12. And when we looked at CDC, it was negative. Flow cross-match, positive. Single antigen bead-based assay, class 1 and class 2 positive. What should have been done? We should have just said that this case obviously should not be taken up for transplant. A lot of people would say that. And maybe some would say, we'll go for desensitization. We just reviewed the mismatched donor alleles in this patient. And this is what the allelic types were. And we looked at the class 1s and the class 2s. And we found there were no donor-specific antibodies, right? So far, so good. Life seems to be a bliss. We'll now go for a transplant, right? But there was one bead which was not represented at all. So the moment there was no representation of a bead, you were actually in a situation whether your SAB was still relevant or not relevant. Now, this is data which is not yet published from our center, where we've reviewed 152 cases. Just look at non-representation of alleles, at least one of them. 74% cases we did not have a representation of our alleles. So much that a lot of you would think, I've done a SAB and I've done a virtual cross-match, don't be happy. You're actually missing out a lot of cases, and whatever you're doing, you may still end up wanting to do a cell-based cross-match for all practical purposes. This is the data which we have from our center, where B and C were one of the most common loci where we had misrepresentation or underrepresentation. And this is something which has already been published on a similar lines from none other than CMC Vellore, where they have very categorically shown that more than 50% of the cases, you do not have full representation of your alleles on the beads that you're using today, be it from any vendor for that matter. So practically speaking, the challenge of underrepresented alleles in the SAB obviously emphasizes the use of a physical cross-match in our population. Till such time, we are able to get our beads having all those antigens on them. And this is the other part of it, which most of us don't even realize. When we talk about shared epitopes, and I'm sure there's an epitopal talk later on or maybe tomorrow, you'll realize the moment you have shared epitopes, the antibody is now going to be shared as well. So your reactivity will go down, and you will not have a positive reaction which you would have otherwise seen in a classical SAB. Add to this a denatured antigen. The moment you have a denatured antigen, you may or may not have a reaction, or sometimes you may have a reaction which actually was not supposed to be. And now you're going to be denying a transplant to someone who ideally should get a transplant. So if you look at this entire scenario, all is not beautiful when you're trying to do a virtual cross-match using SAB or using only the HLA typing part of it. And I'm sure you're going to be listening to a lot more stuff today from Professor Rajarajalingam. I had the opportunity to visit the ASH conference some time ago. This was in Pittsburgh. And interestingly, this was one poster which came out from their center, the UCSF, from Rajarajalingam's lab. What did it show? And I'll just emphasize it here. Just look at this. Certain antibodies do not bind cells. So while you might want to prove that you have an antibody there, what if it doesn't bind cell at all? Aren't you denying a transplant to a patient in such a circumstance? The answer is loud yes, and that's what was presented there by their group. So therefore, when you try to do a virtual cross-match, the virtual cross-match alone may not be useful in our circumstances, especially the places where we're placed. So physical cross-match, let's get physical. Let's start talking about cross-match today, where we do exactly using a cell as well as the sera. There was another interesting name for it when I tried to read about it. They called it wet cross-match. Interesting. So nothing virtual. You take the cells, you take the sera, you mix them up, and then you get the cross-matching done. So I think I have put my case very clear in front of you as far as the pre-transplant or transplant working is concerned, and using a physical cross-match is concerned. I think I would rest my case here. Now it's the smaller part for me. The smaller part is to give you an introduction about how this whole concept works. The concept is primarily about identifying a donor-specific antibody, and obviously we know we are not interested in getting a hyperacute rejection because of a pre-existing DSA, and you would also not want to have a de novo DSA developing subsequently. You would want to pick it up as quickly as you can. And this, of course, all of you know it better than me. I'll not get into details of this, but these are the assays which we are primarily concerned with. So what are we concerned with? We are concerned with assays which are either dealing with cells and the antibodies together, or maybe the antibodies alone. The topic that I was given was to talk about cells and antibodies together, and I have chosen these 3 tests to let you know what these tests are all about. The tests are the complement-dependent cytotoxicity, the flow cross-match, as well as the Luminex or lysate-based cross-match, which still happens to be popular even today, at least among some of us. What are we trying to do in a classical cross-match? It's pretty simple. Just as the way you get a cross-match done in a blood transfusion laboratory, you take the serum, you take the cells, mix them up. Whether they give you death or no death is what decides whether they are compatible or not. And it's pretty simple. And this is the same concept you still do in a classical wet or a physical cross-match. So it's a cell-based assay, and it has to be either a flow-based assay or a flow cytometry, and sometimes even Luminex, and I'll show you that in my subsequent slides. Remember, we are primarily talking about cell-based assay. Now, the moment we say cell-based, we are not specifying that it's an HLA antigen alone. It could be any antigen which is going to attract an antibody on top of it and give you a reaction. So therefore, cell-based assays, which are either the CDC cross-match or a flow cross-match, the antigens may or may not be HLA. What is the purpose of a cross-match? Purpose of cross-match is not to tell you not to do transplant. It's only to tell you that there is a presence of a donor-specific antibody, and what should you do in such a circumstances, what needs to be taken care of by our nephrology as well as the transplant colleagues. And obviously, it's not a contraindication. Obviously, when I talk about CDC, if I don't show you these pictures, it will be blasphemy, because these are the guys who actually gave it to us many, many, many years ago, Paul Terasaki, as well as the lymphocytotoxicity cross-match that we were talking about. And this is what we call the classical CDC cross-match, or what we call a wet assay. Wet assay because you are taking the cells and you're taking the sera and you're mixing them up and then getting the results out of it. How do you do it? You have the donor cells, take the patient's serum, and you mix them up. Once they react, you add either a dye to it or a fluorescent dye to it, and then decide whether you have a positive or a negative cross-match. And this is how it comes about. You either have what is called the exclusion dyes using it. That's the most common one which most of us use because it's relatively cheaper, and it's less temperamental also, if I may call it so. And the others, there are some people who prefer to use fluorochromes, but the moment you use fluorochromes, it becomes relatively more sensitive. However, the issue is that it also is temperamental, because fluorochromes will fluoresce and give you a lot of background fluorescence positivity. So therefore, keeping that in mind, most of us prefer an exclusion dye for doing a CDC cross-match. So this is, the other part of it is we enhance the reaction by adding what is called the anti-human immunoglobulin to it, which then helps us to ensure that we are able to get a much better reaction in terms of cell death, and that gives a better pickup rate. What are the issues? We are all aware of it. Low titer antibodies, non-toxic cytotoxic antibodies, and class 2 antibodies, these are false negatives, and you might have autoantibodies and sometimes irrelevant antibodies which will give you a positive reaction. We'll quickly move into flow cytometric assay. This is again a wet assay, a physical cross-match. Here, this is the gentleman who gave it to us many, many years ago. I'll not get into details of this. But just remember, flow cytometry is primarily three components, the cyto, metry, and flow. That means the cells have to be going into a flow in a fluid media, and then you will measure. Whatever you will do than that, you will measure. And this is a classical picture of a flow cytometry plots, wherein you are able to put the cells across a flow cytometer. You hit the laser on top of it. You get the light which is moving forward. That's called the forward scatter, gives you the cell size. Anything which moves at the 90 degrees gives you the cell complexity, or the fluorochrome which is tagged to it, which will give you the fluorescence. And these rounded or oval objects which you're seeing here, these are either filters or mirrors which help you to direct this light into different photomultiplier tubes. That's what we have called them, PMTs. And PMTs take the light, convert that analog signal into a digital signal, and get you this on a plot. So this is how the laser beam will be there. The forward scatter, as I told you, gives you size, right angle gives you complexity. And important point is what we do in a flow cytometry and flow cross match. You have the antibody, which will go and bind to the antigen over here. It's tagged to a fluorochrome. You put the laser beam on top of it. The laser beam fluoresces. Like anything which gets excited has to come down to the basal level. It comes down to the basal level and emits a different wavelength. And that's what you pick up in a photomultiplier tube. And that gets converted eventually from a digital signal, analog signal, to a digital signal. What can you target? You can target any part of the cell, including the cytoplasm and nucleus. But what we are interested in is the cell surface or the membrane. And this is what happens. We have these plots which come in front of you, and I'll not get into details of that. Just to suffice that we are primarily interested in lymphocytes. And those lymphocytes, we then put this rhomboid or polygon gates. That's what we call gating. And once we've gated it, we then analyze this as T cells or B cells. And then on T cells and B cells, we identify whether there is the presence or an absence of an antibody. This is how a procedure happens. You have the lymphocytes and the serum. And then you have this cell, which is identified as a T cell. If there is an antibody present in the serum, it will go and bind to this cell. And then subsequently, you have an anti-IgG tagged to a fluorochrome, which fluoresces and gives you the reaction. Similarly, for B, you identify it using a CD19, and then you have an antibody which is present in the serum. It will go and bind there, and then you have an anti-IgG again, which will fluoresce and give you a reaction. So therefore, you're using an anti-human immunoglobulin to identify the antibody which was present in the serum that is gone and bound to a cell here. So it's again a wet cross match, a cell with an antibody, and then an anti-antibody. And this is the same concept which we adopt for IgM also. A lot of people do IgM flow cytometry as well for cases. And we have something called median channel shift. For the paucity of time, I'll not get into details of this, but this needs to be established in different laboratories, and it will vary from a lab to lab. However, the ratios will actually give you a better identification. And then there is interpretation of flow cross-match. Again, I'll not get into details of this, but just to suffice that flow cross-match, if it's positive, please take it very seriously and try to identify what's underlying in that particular case. This is how a classical flow cytometry plot will look like. You will have these mononuclear cell gates. You will identify your T cells and B cells. And this is the IgG reaction which you will get on a histogram. And when you have a case wherein there is a positivity, just see there has been a significant shift of this histogram from the left-hand side to the right-hand side. And that shift is what is called a median channel shift. So you have numerical data which you are able to pick up from the background and give the MCS. Again, for IgM, similar kind of a concept. I'll not get into details of this. But there are lots and lots of other things which have started happening with flow cross-match. And again, it's a physical or a wet cross-match, wherein we are looking at an improved cross-match using pronase. We have started using that as a part of our routine activity. We also had an insight in one of the workshops this year where Rob, in fact, gave us an information that, using only lymphocytes makes it more sensitive. So we've also started adopting that and found a change or a difference in that. And in addition to that, you can also do what is called a cytotoxicity cross-match on flow cytometry, again using a wet platform and giving you a physical assay. There's another thing called endothelial cell cross-match. We've had some little experience of it some time ago. We have not been able to lay our hands on the kit yet again, but hopefully this year we should be able to do. All you try to do is get the endothelial cells. The only problem is that when you start this test, you need to take a higher volume of blood, 50 ml or more. So you can imagine any patient, the moment I take more than 10 ml, he starts thinking that I'm going to drink that blood. And now I'm going to tell him 50 ml. Imagine what's going to happen. Heavens are going to fall. But anyways, Nevertheless, the idea is that you're trying to get endothelial cells. The endothelial cells come very minimally in your sample, and then when you try to extract them using a negative selection, on that, then you put a flow, and you find out whether you have a positivity or not. Talking about solid phase assays, that's not my domain. But why am I showing you a Luminex here is only for one reason, because I'm going to show you what is called the lysate-based cross-match. Lysate-based cross-match is again based on the same flow cytometry principle. The only difference is that you have two lasers actually, identifying, one identifying the bead and the other identifying the reaction. And this is again a wet cross-match. Why am I calling it a wet cross-match? Is I still lead lymphocytes. I still will take my lymphocytes. I'll prepare a lysate out of them, and I'll quickly show you that. So this is what happens. We prepare a lysate out of it from the lymphocytes, and then we put it onto a capture bead. I'll quickly finish now. And in this capture bead, we incubate, and eventually we wash them, and then finally put it onto with the serum. Your antibodies will go. The assumption is that the lysate which has come onto these beads is actually going to give you so-called HLA antigens and other antigens, and then this antibody is going to go to bind to it, and it's going to give you a beautiful reaction, and eventually you are able to identify whether there is a positive reaction or not. Again, capture bead, as I said, you have a capture bead, it's taken up the lysate, and then you have the antibody which goes and binds onto it, and on top of it you have a antibody which is stacked to a fluorochrome, which eventually gives you a reaction. Well, this is how the reaction will come out. There are a lot of confusions and chaoses in this assay, but nevertheless, if you look at this assay theoretically, it seems like a perfect test. You can't get it better. You would have taken a lysate, which is from the individual, from the donor. It's gone on to the lymphs on the bead. You're taking a serum, making it react. Wonderful. But does it really work like that? The answer is no. It fails to detect a lot of antibodies like DQs and DPs. And there's enough evidence in the literature. We've also published some, and some non-specific positivity which also comes in on Luminex cross-match, especially the lysate-based. And compared with flow cytometry, it's not found to be not found to be better. In fact, flow seems to be a much better test. So in my opinion, I would probably let it rest to peace. This has already been shown by a lot of people, including Dr. Shruti in her present publication last year. Coming back to the assays, as I showed you, cell-based assay alone, as a CDC alone, may not be right, may not be the panacea for you to do your testing. But let's combine them together, two cell-based assays, and we'll still be able to give you a much better reaction at a much lower cost, and invariably in more than 80 to 90% of the cases, you will actually go home safe. This is just a comparison. You can refer to the publication which is there. I'll not get into details of this, again, for the want of time. But just to summarize, if you look at the tests that I gave you in my last 15 to 20 minutes, you will realize only one thing. No test is perfect. Physical, virtual, whatever you may want to call it, no test is perfect in the art of defining HLA-specific antibodies, and that's why it's the case which determines what you want to do, and eventually a multimodality approach is all that will help you get you to the right possible solutions. And remember, it's the man behind the machine who's very important. When we do these tests, who's actually sitting down, interpreting your tests, and then eventually giving a value is what is very important. I'll just give you a quick anecdote. When I first started doing SAB assay about 15 years ago, I would never bother about representation of the alleles in that. I would just say SAB negative, all good. But today, I'm very worried. The moment I get a SAB negative result, the first thing I do is I want a donor typing. I want my SAB, the entire profile of the SAB. And I also want to check out, are there any shared epitopes? And I'm sure some of that will be spoken about in the subsequent lectures. So the man behind the machine, how trained is he? How well is he looking at your assays is equally important to get to a final conclusion. So I think with that, I would stop. This is to acknowledge my team back home. Thank you very much for your kind attention. For any questions, I'll be happy to answer.
Sir, before we open to the audience, I would like to ask a question. Now, a couple of decades back, we would just do a CDC, even in live-related situation, and do a transplant, and most of the times things were fine. We have now started incorporating flow cross-match in the living donor scenario, but in the deceased donor scenario, it is still not possible in so many cities and regions to incorporate flow cross-match. So my worry is how do we get over this barrier?
Okay, so you said, I'll just take your words only, and you said you used to do a CDC, we used to do a CDC as well, and most of the times we would get away with it.
No,
But
we're still continuing to do
yeah,
CDC.
even we do that. But the word is most. Most of the times you would get away with most of the good transplants, but there would still be about 5, 10, 15% cases where you will have a challenge. That is where all the other assays become important. Anyway, the question is not that. What you've asked is a very specific question with respect to deceased donor transplant. As far as deceased donor transplant is concerned, there's one very important challenge which we all need to understand. CDC is deciphering CDC for a deceased donor transplant is really difficult, because by virtue of a dead man's cells being taken out, the cells are already fragile. So I usually get a cell death, and I'm sure people who are doing deceased donor transplant cases, they would realize that you have a cell death in the background itself. So deciphering a CDC for a deceased donor transplant is relatively more difficult. The question is flow a better assay compared to CDC when we do deceased one? The answer is yes. It gives you a better assay. You're able to get your dead cells out of your contention as far as the assay part of it is concerned, and you're able to get a better result. The challenge though is, will you be able to get access to flow cytometry at that hour in your city? The answer is difficult to answer. Tier 1, maybe most of the people will be able to do it. For example, in Delhi we do it, but then not in every place. But there is an interesting thing which is happening with BMST there, and I'm sure Ankit will be able to guide us better, where they have started doing the SABs up front, right? Or the PRAs up front, and using that as your subsequent assays for deciding whether you will go ahead and putting the patients on a wait list kind of a thing. And that is, in fact, some of the centers prefer to do it every 3 months, so that to see if there is no new antibody coming in. But that will increase your costs. So it will be a trade-off any which way.
So if PRA is negative, we can get away without doing flow. Is that what you're saying?
I would still not do that. I would prefer to do a flow, but if I don't have any other option, well, so be it.
Yeah.
Sir.
Yeah. One question, sir. It was an excellent presentation. My question is, if lysate-based DSA is negative, then is there any possibility of SAB-based DSA coming positive?
Sir, I showed in my last slide, I have put it to peace. Rest in peace. I wouldn't rather really do a lysate-based assay. But if I have no choice, and that's the only option available to me, I would do a lysate-based assay. Your question would be, does lysate-based assay correlate very well with SAB? The answer is no.
If lysate-based cross-match is negative, DSA is negative, then does that exclude SAB-based
Positivity?
DSA positivity?
No, not at all. So invariably, that's what I said. I showed you in my presentation also. There are certain antigens which are not represented appropriately on a lysate-based DSA. They're not adsorbed appropriately or adhered to the bead appropriately for them to give a reaction. So therefore, lysate-based assay vis-a-vis SAB is not a better assay. SAB is definitely a better assay, far ahead assay, and lysate is only a surrogate which is like just to tell yourself all is well. It really doesn't help.
Thank you.
Thank you.
Thank you, sir, for that engaging presentation on physical cross-match. Thank you, chairpersons. Now let's move into the world of solid phase assays. I'd like to invite the chairpersons onto the stage, Dr. Manoj Matnani, consultant pediatric nephrologist and renal transplant physician from Jahangir Hospital and Dr. D.Y. Patil Medical College, Pune. He was awarded the gold medal Dr. V. Balagopal Raju Endowment Award for the research work on nutritional value of tropical oil application in neonates, and a national award, the Dynamic Indian of the Millennium Award. And Dr. Anil Tarigopala, senior consultant, cytogenetics and molecular diagnostics laboratory from Coimbatore Kidney Center and Multi-Specialty Hospitals, Coimbatore. He has multiple publications in peer-reviewed journals, and he's an NABL technical assessor for molecular testing and histocompatibility. I'd like to request the chairpersons to please introduce the speaker.
Okay, so without further ado, thank you so much for inviting us. And Dr. Firoz Aziz is in front of us. He's a consultant nephrologist and clinical director at the Transplant Immunology Laboratory at ICRA Hospital and Research Center, and at the Aster MIMS Hospital from Calicut, Kerala. So over to you, Doctor. Thanks.
Respected Chair, teachers and friends, thank Sir and Shruti, Prashant for inviting me on behalf of my team. Okay, so basically I would be just concentrating on the solid phase assays and the clinical aspect of it. Just like Dr. Handu told, nothing is black and white in transplant immunology. So if you look how the transplant histocompatibility testing has evolved over the years, it started with cell-based assays and subsequently solid phase assays had to come. It came in quest of a clinician's pursuit to have an algorithmic approach for histocompatibility testing. So a clinician wants to know whether a patient has an anti-HLA antibody. If so, is it donor specific or should I avoid a transplant? So the last question was answered first by getting the cross matches. But subsequently, we had to resort to solid phase assays to get the former questions answers. So with 2013 consensus in place, you have to have a cell-based test along with a solid phase backup to clear for a renal transplant. So the first question is to screen for antibodies. Now we look for the presence of anti-HLA antibodies in an individual. Now we have tools to screen, but conventionally it was to detect for panel reactive antibodies where a patient's recipient sera is tested against a pool of antigens which is representative of the donor population. So actually for that, ELISA, flow, and Luminex as solid phase assays came into existence in histocompatibility testing. Basically, the purified HLA or the recombinant HLA are extracted and stuck onto these solid phase phases, and your sera is run to identify the antibodies. So basically, now the CDC and ELISA PRAs are obsolete. Now we have the flow PRA and the Luminex. Flow PRA is still, from a PRA tool standpoint, Flow PRA is as good as Luminex PRA, but because of the versatility and the multiplexing nature of the Luminex, pretty much it is dominating everything as far as solid phase is concerned. So this is how the Flow PRA is. You have like 30 odd beads. It is just like a donor cell, okay? Each bead is just like a donor cell, except for the fact that class 1 and class 2 is separate, okay? And so if you react to certain percentages of beads, it will give you a percentage. Here you have the blue one, class 1 is negative, and class 2 is like 80% positive PRA. So coming to the Luminex, so you know that is the most sophisticated instrument around, platform around, nothing but a flow cytometer, and the whole reading comes on what sort of a donor cell or what sort of a bead that you are feeding the flow cytometer, the Luminex platform. So basically, just like Dr. Handu told, it has got two lasers. One detects, identifies the bead, and other looks at the reactivity. And from HLA antibody testing standpoint, we have like three beads: the mixed antigen screening bead, the PRA bead, and the single antigen bead. So the mixed antigen screening bead is the very fundamental, which is a very cost-effective bead, which we have been using for almost like 7-8 years. All the common HLA antigens are stuck onto these beads, and it just gives you a qualitative result, like positive or negative. One of the vendors give similar sort of a pictorial representation, and these are different, different combinations of different positivity. And one thing that we do is that if only one class is positive, we just do SAB of that as a money-saving this thing. This is another vendor has it in a tabular form, but the message is the same. It gives just a qualitative information whether he has an anti-HLA antibody or not. So we had like 640 NGS typed individuals in North Kerala. At the serological level, we looked at both vendors. They are 100% representing at a serological level. And this some sort of a congruence is there. You can see, the beads and the screening bead and the width of the single antigen bead. It gives a valuable information many of these times. Second is the phenotypic bead. It's just like we discussed the flow PRA. Each bead is just like one individual, and it is actually denatured HLA, from the mammalian cell lines. So the advantage is that the three-dimensional structure is pretty much intact. So it gives some sort of a more physiological read compared to the recombinant HLA of single antigen bead. So each bead has got, again, it's class 1 and class 2 is separate. So each bead has got A, B, and C, two haploids. And, based on the percentage of beads that lit up, you say so much percentage PRA is there. And this is actually, we don't do, I got it from Dr. Manish Balwani's lab in Nagpur, they do it, and this also, each bead is like just one individual, it has got 2 A's, 2 B's, and 2 C's. So this is class 1 positive and other is class 2 positive. Basically, it gives you, again, some sort of little more of a qualitative information that this patient is sensitized. Now coming to the single antigen bead, I think all of you might be knowing the basics of it. Each bead is one antigen, and each column represents one particular antigen. And at the end of the day, partly vendor-driven, partly your lab-driven, you have cutoffs each lab, and above which you say that this patient has so many antibodies, and you look at the donors and see whether you have got donor-specific antibodies. This is basically what we say the fundamental virtual cross-match. So pretty much Luminex has everything from screening to PRA to single antigen bead. But let us see the negative side of Luminex. One is it is too sensitive, okay? So these are data from Paul Tarasaki's and Opel's labs, they are pioneers in transplant, doyens in transplant immunology, Almost 30 to 60% of the patients are having some sort of anti-HLA antibodies, though the MFI might be 1,000-ish, but it's irrelevant information for a clinician in clinical decision making. And ASHI-accredited labs have shown to have 40% variation in MFI reporting. And false negatives, that means you have antibodies in your system, but it is blocking, it is being prevented in attaching, in getting bound to these beads. And you have false positives where your beads become, because they are recombinant beads, so they go through viral vectors, what happens, they become denatured, cryptic epitopes get surfaced, and you can give you false positivity. And just like the way the HLA is expanded, we just have 100 and 120 beads to define our response. So this is these are the negatives of single antigen bead that we use routinely. But as a clinician, I think we should be aware how to analyze a single antigen readout. Okay, just like you look for a ECG, make sure that your controls are working okay. And second is that you should have a recipient and a donor typing to see how it is, because you don't respond, you don't create antibodies to yourself. So the beads represent your own HLA should be at the tail end, which should not ignite much response. Similarly, this is another broadly sensitized patient, but if you actually, the beads at the lowermost and the tail end is what I can zoom that, it is basically the self antigen. So it gives you a feel that, okay, this is a decent single antigen bead readout. And now the cutoffs. Cutoffs, again, it is partly vendor-driven, lab-driven, but it is pretty much globally we have accepted that for the most important loci of A, B, DR, and DQ, 1,000-ish is somewhat we have all in agreement. Coming to C and DP, there are some sort of a supraphysiological beads, you have supersaturated stuff. So there is an allowance for higher MFI. But if a patient is like broadly sensitized, many times different labs have different approaches, just to take a cutoff, just to see the patient, the beads with the most high MFI to be, this is just, it's some sort of a personalized strategy by certain labs in broadly sensitive patients, they might relax the cutoff a bit. But the most important thing is the patterns, okay? I think Dr. Handu mentioned it in between, because it outweighs MFI, okay? So we are like 200 people in this room. Each, from HLA standpoint, we 200 might be different. So that is the polymorphism of HLA. But between these HLA molecules, there is a lot of homology. So basically, you react to islands of polymorphic residues, which we call as epitopes, and the epitopes are shared by different cross-reactive groups. So highly unlikely that you go and just attack B57 without attacking B58, okay? And people have identified epitopes with these cross-reactive groups. So, but fundamentally, in our lab, we use this one, which we feel a lot of comfort, we feel very comfortable with that. So basically, there are the traditional correct sheets. So if you have an antibody profile like this, what sense does it make? But when we converted it into a correct sheet, everything is falling into A2 correct. So a donor outside this correct would be a donor that would be a suitable donor. So again, highly immunogenic, another epitope pattern is the BW4 and BW6 pattern. These are BW4s and BW6 are each HLA-B will have either a BW4 or a BW6 as a public epitope. And unfortunately, if you develop an antibody against that public epitope, the whole group will be hostile to. This is the BW4 pattern, this is the BW6 pattern. There can be combination. This is A1 and B7 corrects together accounting for this traffic, okay? And this is actually a partial correct, Within the B5 correct, you have a B15 subcorrect, and the antibodies are just to that. And this is class 2 correct, B50 correct. Most of your patients who are waitlisted, you can see, this is a common thing that we see in waitlisted patients with class 2. This is again DR1 correct, again another class 2 correct. So this is interesting. So you don't develop antibodies to yourself. Actually, this patient has got a A2 correct, but he has got A4, his self-HLA type is A24. So he has not reacted to A24, but he has reacted to the remaining part of the correct. So this is another A2 correct, but the whole MFI is less than 1,000. So that is the problem with the cutoff. You have a pattern there. So pattern trumps the cutoff. Suppose this patient has got some reactivity in flow, then the whole MFI, the significance of the whole graph differs. So coming to C and DP, they also come in groups. C has got two important blocks, and this is the C epitopes, and this is the DP. And this is one of the DP. So usually C and DPs come in blocks, they stand very close to each other, back to back. And again, this falls into one of these epitope patterns. But basically, in our lab, we ignore C and DP if the flow is negative, because primarily it's a living donor program. We don't know what to make out of it. So if the cross match is negative, we ignore C and DP at this point. And I think the data is not that robust on long-term outcome as far as C and DP is concerned. Now the issue is that, do we need high-res typing for the donor, to make a good sense out of this thing, okay? So these are the single antigen bead of both vendors. 30% of the beads have got at allele level beads, and the subserological level, okay? And so when you look, usually the reactivity, I think when you see the reactivity, it is pretty much, okay. So you see all the old A2 coming stacked together. It may not be that close, but usually they behave like that, okay? So you see all the B40s coming very close together, A68. So the serological level, I mean, it's okay, okay? So this was, again, A2, though need not be very close together. So basically, they react to a serological pattern. So in majority of the cases. So you don't need a high-res typing. But this is an important study from University of California, San Diego. They analyzed 5,000 samples, and they found that 15% of the cases, they had been antibodies at an allelic level. So that is a number we are saying, okay? This is the number that, when we, okay, if your pattern suggests that you want a 4-level typing, that is well and good, but by and large, if you make a policy of you need high-res typing for everybody, I think this is the number that we should have in mind. 15% definitely needs it, but rest is your center's choice. A1102, DRB1, 0402 are certain things that usually differentially behave from a serological standpoint. Now, as a clinician lab, you know that so many donor-specific antibodies are there. Now the buck stops at the clinician's nephrologist's desk to whether to transplant or not, okay? So let us rewind a bit. This is the CDC era, okay? This is from Lafourchard, who is going to be one of the speakers tonight. So what they found was that they proceeded with transplant with the CDC negative cross-match. But retrospectively, they had the day 0 serum, and retrospectively they found that 20% of the patients had donor-specific antibodies. And it is the donor-specific antibody patients who had inferior outcome. Now the devil is in the details. Now they teased out these people. So what they found is that the donor-specific antibody patients who developed AMR, early antibody-mediated rejection, they had inferior outcome. There is a subgroup who had DSA but did not have early ABMR. They did fine. They did fine just like they did not have a DSA. Okay? Same thing also came from the Switzerland group from EMICO. Same data. Okay? 334 patients, 7 years follow-up. Okay, only those patients who having a DSA with the ABMR, that combination actually had an inferior outcome. So again, from Mayo, this has been a consistent data. So now the question for the clinician is, now you have to have whether this DSA is going to create early ABMR. That is the question. If you answer that question, then you have a way forward, okay? So the patterns and titers we discussed, it gives you some information, not 100%, but people have worked on different fancy antibodies, but nothing have stood the test of time except the flow cross match, okay? So if you have a DSA with a flow cross match positivity, that is where the decision making ends. So I think Dr. Handu showed the same slide. In this flow era with 100% sensitivity with this thing, I think the flow cross, so you have to have a standardized validated flow cross match facility, then it makes your life easy in decision making in patients who have DSA. So the only contraindication where you are justified in avoiding a donor is a DSA with a flow positivity. Others are all relative, your choice, your center's choice, okay? So if you have a cross-reactive pattern, very strong pattern, or A2 pattern, or D53 pattern, it's your choice, but it's not an absolute contraindication, okay? Again, one thing which again, people say that, which is, I think, I also do the same, because I try to avoid, especially the class 2 antibodies, if it is from your previous donor, okay? Especially. So the point here is that even at the CDC, even if you look here, okay, 60% of the patients had a 6-year graft survival. Well, it's not like that. So that's why, So in India, what are we going to offer the patient, okay, if you're denying a transplant? That is the issue. So I'm just winding up here. I think solid phase assays are going to stay, without which histocompatibility evaluation will be incomplete. Luminex platform prevails. It's very versatile multiplex, but at the end of the day, your SAB, your DSA, you have to take a call based on your reactivity pattern, your prior memory response, the type of this thing, and finally the cross-match positivity. I thank my mentors, thank my team. Thank you all.
That was a fantastic talk. I think I'm definitely floored with the amount of experience that you have. I think you covered almost everything about single antigen bead assays, the PRAs and other things. So due to paucity of time, we will have one question from the audience. So all these, you have developed your own algorithm with all these, right?
Actually, it's basically the Delhi algorithm. We do screen and we do flow.
So it's a very dynamic.
Then you identify, like, oh, got it.
Fantastic work, sir. Thank you.
Thank you, sir. Thank you, chairpersons. From the HLA world, now let's shift into the non-HLA zone. The next talk will be on the non-HLA antibodies and applications in daily use. I'd like to call upon stage the chairpersons, Dr. Prashant Rajput, consultant nephrologist and transplant physician from Gleneagles Hospital, and Sir H.N. Foundation Reliance Hospital and Anil Clinic, Mumbai. He has multiple papers and publications in various national and international journals and conferences. And Dr. Ankit Mathur, Additional Medical Director from Rotary TTK HLA Lab, Bangalore Medical Services Trust, Bangalore. He has a fellowship in transplant immunology from Ohio State University. He's scientific secretary of the Asian Association of Transfusion Medicine, and he's an NABH assessor. I'd like to request the chairpersons to please introduce the speaker.
Good evening, everybody. So, speaker for this talk is Dr. Rajalingam Raja. He is a professor of clinical surgery and director of immunogenetics and transplant laboratory, University of California, San Francisco. And his topic for today is challenges in determining the value of non-HL antibody test for kidney transplant because of other confounding variability. So, it's a virtual talk online. Thanks, Dr. Rajalingam, for joining. And over to you, Dr. Raja.
Dr. Sruti, as well as the organizers of Transplant Immunology Simplified, for inviting me to give this talk. Actually, I was supposed to be there in person, so I could have enjoyed more. It seems to be a lot of nice talks going on. People were showing in the cell phone, the people in the room as well as the presenter. So I could have learned more or interacted more than I am there. Anyhow, so I was asked to give a talk on the utility of non-HLA antibody testing. So I can start with summarizing. So what is the current situation on this utility of non-HLA antibody testing? It is still under research. It is not ready for clinical utility. So that's the take-home message. So with that, I'm going to share my slides. I hope you are seeing my slides. Let me put it in the, yep. I'm not sure you see my slide mode. Maybe I don't see anything here. Okay, I will. Okay, so I'll present as such instead of putting in the slide more. So I changed my topic a little bit, indicating the real situation, talking about the challenges in determining the value of non-HLA antibody testing in kidney transplant because of a lot of confounding factors. This is my conflict of interest slide. So I received honoraria from Imicor. Currently, it is called Warfen, as a key opinion leader. I also received 3 non-HLA antibody testing kits from the Imicor to address the specific research questions, and I will discuss the results in this presentation. If you look at the literature using these keywords, non-HLA antibodies and rejection, you can pull over 327 publications in the PubMed. There's a significant increase in the number of publications on non-HLA antibodies in the recent years, the last 10 years. But most of these reports are coming from a research lab in research setting, and most of them are also coming from the heart transplant setting, not kidney or lung transplant setting. So this is a summary of non-HLA antibody testing situation in heart transplant setting. There are several non-HLA antibodies have been identified. MICA and anti-AT1R receptor antibodies. So these two are known, results are published in the literature because One Lambda is making these reagents for these antibodies. So it is driven by the publication, certain publication. Because the commercial reagents are available, you can see more publications. So people should understand there is a bias in the utility in the publications. The women thing against a pure research, particularly it is very commonly published in lung transplant setting. Then the anti-endothelial cell antibodies, otherwise called endothelial cell cross-match. This is probably only test that used across all the transplant organ type to detect non-HLA antibodies, because in theory, the endothelial cell probably covering all non-HLA targets. You can see the prevalence of these non-HLA antibodies in heart transplant setting. but we don't have any data in kidney transplant or lung transplant setting. But in heart transplant, there are a lot of, it's like a 10 to 15%, and AT1R, you can see 50% of the heart transplant recipients can make this anti-AT1R receptor antibody. So there are major challenges in using non-HLA antibodies. First of all, the non-HLA antigen expression in allografts are unknown. We don't know what type of non-HLA targets are expressed on the kidney or heart and lung. There's no one identifies what is the expression level. Again, never been defined. Then the pathophysiology of non-HLA antibody binding mediated graft injury is not defined. Whether it binds fix or complements, we know generally to fix a complement, we need a lot of antibodies in HLA antibody setting. But non-HLA antibody seems to be low level compared to HLA DSA. So there's a big question whether it can even bind complement. If it is not binding complements, whether it is mediating antibody-dependent cell site toxicity. So those questions have never been addressed. Then the big problem with this non-HLA antibody testing is the performance characteristics for the testings. We don't know the sensitivity, we don't know the specificity. In fact, we don't have any control serum because you are testing for hundreds of non-HLA targets. There is no way to use a particular serum to control this assay. Therefore, if I run samples, I may come up with the different results, and there's no way my results are, or my lab results are working perfect because there's no control values. So, for example, the endothelial cell crossmatch, which has been widely used to detect non-HLA antibodies, if you take that, it itself, endothelial cell crossmatch itself comes with the complications. So what I'm showing here is the four different endothelial cell lines, like a TE, HU, HY, HM. These are the cell lines, endothelial cell lines. Anyone can buy from the commercial companies and grow them in the lab and use it as a cross-match, endothelial cell cross-match. So when we cross-match with this negative control serum, doesn't have any HLA antibodies, you can see that the reactivity of each cell line is very different. This particular cell line, HM, reacts with very low level, like a 50 median channel saved. The 15 median channel, and the blue one is like 3 times more than the purple one. So there's a huge variation in the reactivity of just even the normal control serum. So that tells the expression of this non-HLA target can be entirely different. So then there is no correlation between endothelial cell crossmatch and the rejection. For example, here, so this is the 6th endothelial cell line has been used to do the crossmatch. You can see patient number 8, no HLA antibodies, but the crossmatch, endothelial cell crossmatch with this all 6 cell lines are negative, but you can see there is a graft failure. On the other hand, you can see all 6 cross-matches, endothelial cell cross-matches are positive, but the graft is functioning. So there's no absolute correlation that can suggest the utility of these assays in clinical transplantation. But people using it because it is considered to be the immediate target for antibody-mediated rejections. It is lining up here in the blood vessels, so people think it can be direct targets, and it presumably express the endothelial cell presumably express all non-HLA targets, and also it is easy to set up here as a cross-match assay in the HLA lab because we always do T and B cell cross-match, just exchanging the cells T and B cells. We can use simple endothelial cell lines. But we talked about a lot of challenges. So, but the real truth is there are some percentage of kidneys are rejected without HLA donor-specific antibodies. And you can treat those rejection by plasmapheresis and IVIG. Is very similar to the treatment option for HLA-DSA. So people, that there is a clinical significance. There is a HLA, non-HLA DSA is there, but we don't have any testing system to absolutely identify those non-HLA antibodies. So in our center at University of California, San Francisco, 1.5% of the kidney transplants are rejected without any HLA DSA. So that means there's a role for non-HLA antibodies. But all these patients can be treated with the plasmapheresis and IVIG, so they get better. So we used very recently developed test methods. It is very simple, similar to the single antigen assay. The Immucore non-HLA panel, or Immucore nowadays Warfarin, come up with this Luminex panel of 96 beads coated with the 96 different non-HLA proteins. So the one lambda also having very similar system. Because we did the work with the Immucores, I'm going to present on Immucore non-HLA antibodies. You can see these are the antigens and the gene names, and a lot of them are collagen. So these non-HLA targets are collected from the literature, from the research studies, and it also covers all solid organs, so kidney, heart, and lung targets. So they have one system to use it for testing non-HLA antibodies across different solid organ transplantation. So the assay is very simple, just identical to how we run for HLA antibodies. You had 40 microliter of antigen, the bead mix, the Luminex bead mix, with a 10 microliter of serums and 30 minutes incubation at the room temperature. Then wash and remove these unbound antibodies in the serum. Then you had the secondary antibodies conjugated with the PE. Then you detect in Luminex beta. So the workflow is very similar to single antigen antibody assay. But the problem is setting up the cutoff value. So unlike HLA, we have people use one cutoff, like 1,000 or 2,000 MO5, but here each non-HLA is a very different target. So the Immucore come up with setting up a different cutoff value for each non-HLA base. So what I'm showing here is so they took 100 sera from non-transfused males. They don't have any sensitizations. So then when they look at each non-HLA antibody target, so then here's a particular non-HLA antibody target, PRKCZ. So the x-axis indicates the MF5 value starting from 0 to all the way to 20,000 MF5. So here's the frequency of individuals within this 100 individuals positive are showing MF5. So like majority of them are showing within like a 2000 MF5. So, but we need to recognize some patients, like 15% of the healthy controls can make strong non-HLA antibodies. So this is across all 96 beads. So then this is our study cohort design, because we need to be very careful. We don't want to interfere with the HLA DSA. So we pull all the kidney transplant done during this time period from January 2013 to 2018. So we put them into two different categories. It's I have animation, but I'm not sure it works. So I'll walk through slowly. So we selected the patient based on the pre-transplant DSA and whether they have no DSA, pre-transplant DSA, or presence of pre-transplant DSA. Then in terms of graft outcome, whether functioning or failed, we split them into two groups. Then again, we split them based on the formation of de novo donor-specific antibodies. So we come up with like 8 different groups based on the pre-transplant DSA rejection episodes and the de novo donor-specific antibodies. So this particular, the green group, that's a group 1, is kind of control groups. There's no HLA DSA either before transplant, after the transplant, then the graft is functioning. So in theory, this group of people, we selected 26 patients, should not have any non-HLA antibodies. Then other direct comparison is the red circle boxes where you have no HLA DSA, either preformed DSA or de novo DSA, but there's a failed graft. So this graft failure is due to non-HLA antibodies. So in these patients, we have 16 patients, we should see strong non-HLA antibody signature. So there are other groups having either preformed DSA or de novo DSA, so we cannot directly compare the outcome of these kidneys because of due to non-HLA antibodies. So then we took like 167 individuals, but you can note these 4 groups, because so many patients, we selected only the highly sensitized patients in HLA antibodies, over 80% of the CPRA individuals, to keep like consistency. Then we took serum, pre-transplant serum, as well as serum at the time of ABMR diagnosis. Then if the graft is functioning, then we took most recent serum tested for the individuals. So when you look at the data, we have like 167 individuals. So this is the raw data. So here is all these 96 single antigen beads coded with a non-HLA antigens. So these are the functioning graft individuals, different patients. These are the pre-transplant serum and post-transplant serum. The numbers are too small, you don't need to read, but I put it in 2 different colors. The black color is negative, the red one is positive. So that goes beyond the threshold. So if you look at red color, those are the positive antibodies, non-HLA antibodies. So you don't see any pattern, something, so you can compare to pre-transplant and post-transplant in this functioning graft. Then we look at the same way in rejection group. Again, there's not much patterns. You may see more red in the rejection group, both at the pre and post-transplant, but certainly there is no grouping or pattern. So what we did, we counted for each patient how many beads are positive. So like patient number 1, how many beads are positive, that red color one, divided by the number of beads that we tested, that gives a PRA value. So let me see. So this animation doesn't work. So here it is a non-HLA PRA. So it's a non-HLA panel reactive antibody. So this is the number of beads positive divided by the number of beads tested. So that gives you like a single numerical value. So using this value, we can compare head-to-head the pre-transplant versus post-transplant, as well as rejection with the non-rejection groups. So that's what we did here in this slide. So we took all these 167 patients. This is the pre-transplant values, post-transplant values. So each patient values are connected by this line, but also we provide the mean and standard deviation boxes here. So you can see, compared to pre-transplant, post-transplant, there's a significant decrease in non-HLA PRA. So in general idea is, if you transplant in HLA1 and HLA DSA, you transplant, the DSA is increasing after transplant, but in non-HLA PRA seems to be decreasing after transplantation. So these are our immunosuppression, so we don't take, I mean, these all very normal immunosuppression regimens in any transplant program. Then when you split these patients into functioning group and failed group, so the functioning group, what we see, there is a decrease in the non-HLA PRA in post-transplant compared to pre-transplants. So that's the function, but the failed group, you don't see any difference. The same level of non-HLA antibody persists in both pre and post-transplant. So what that means, here in failed group, probably making consistent non-HLA antibodies, even the grafts cannot absorb so that you can see it in the circulation. That's kind of hypothesis. This is just explanation. So again, failed graft, you don't see a difference in the level of non-HLA antibodies at pre and post-transplant, but the functioning graft, there is a significant decrease in the post-transplant serum. Then what we did, we refined these two groups, based on the options of DSA, preformed DSA and de novo DSA. So these are the two groups. Here is the pre-transplant DSA negative, de novo DSA negative, no graft rejection. So that is group 1, 26 patients. This is opposite group, so there is no DSA, HLA, DSA, the preformed or de novo DSA, but there is a rejection. So this is the perfect group comparison. So you can see here, the rejection group, you see the level of non-HLA antibodies are unchanged compared to pre-transplant serum. But in the graph functioning group, there's a significant decrease in the post-transplant serum. Then we want to ask the question what triggers these non-HLA antibodies, because of transplantation or pregnancies or all those immunization. So that's what we did. So we put them into two different groups, like a transplant who received a transplant before, or the first transplant candidate. When you look at the data, you can see the first transplant candidate. So in all group, there is a decrease, okay, because there is a rejection. Then when you look at here, the first transplant and retransplant group, the pre-transplant serum, that red dotted one, you can see a significant increase in non-HLA antibodies in the retransplant candidates. So the retransplant candidates make more non-HLA antibodies. This is because of the transplantation probably triggering non-HLA antibodies as well, just like HLA antibodies. It's similarly true here in the woman. It's like a female make more non-HLA antibodies. It's again due to the pregnancy. So the take-home message is the unknown immunizations, either by transplantation or pregnancy, can trigger non-HLA antibody production. So then splitting this group based on the transplant, male and female and male. So it's the functioning group and the failed group. Again, the failed group, no change in the non-HLA antibodies in pre and post-transplant, but the functioning graft, there is a significant decrease in the non-HLA antibodies. So then we look at, is there any correlation of non-HLA PRA with the ABO group? No, nothing. This is pre-transplant data, post-transplant data is pretty much very similar. Then we also look at the ethnicity. Then when you look at the African Americans, seems to be making more non-HLA antibodies compared to Caucasian group. So that tells the ethnicity is matters, particularly African Americans are vulnerable making more non-HLA antibodies. Then we also look at the underlying cause of kidney disease, and we found the IgA nephropathy patients making more non-HLA antibodies compared to any group. So I'm showing you just compared to diabetes group. You can see the high level of non-HLA antibodies are made in IgA nephropathy. Then we want to check, how stable these non-HLA antibodies if you collect the serum and test in multiple serum in different patients. So what I'm showing here is that this is the transplant time occurs. This is the pre-transplant non-HLA CPRA in different patients. So each line represents a particular patient data. So these are the time points in month. You can see there's a lot of variation is going up and down. So it is not like a stable. This could be another technical challenges as we see it in HLA single antigen assay. But when you look at individual patients, the pattern seems to be conserved. So what I'm showing here, so these are the color-coded one is the serum collected, multiple serum collected from the same patients. Like a green, all these 6 samples come from one patient, so the blue from one patient, gray from another patient. So what you can see that there seems to be some pattern, like all serum coming from this green patient having this non-HLA antibodies. So what it tells, the patient probably having the signature non-HLA antibodies, every single serum you tested. But if any changes like up and down, that probably due to this additional non-HLA antibodies. So then we also correlated with the endothelial cell crossmatch, and we showed this slide before. We did the 6 endothelial cell crossmatch. There's absolutely no correlation between the crossmatch, endothelial cell crossmatch, and the graft outcome. So here is the all 6 endothelial cell crossmatch negative, but the graft can be failed. Or 6 crossmatch can be positive, but you have functioning graft. When you look at the non-HLA PRA, again, no correlation, much correlation. Probably we need more data. It's not even clear. So in summary, transplant and pregnancy-induced allosensitization appear to trigger non-HLA antibody protection. An African American exhibit high non-HLA PRA, and patient with IgA nephropathy exhibit high non-HLA PRA. And certain bead activities, reactivities can be patient-specific and are stable over time in different serum. And certain bead reactivities varies, which yield fluctuation in non-HLA PRA value over time. There's no correlation between non-HLA antibodies and endothelial cell crossmatch, and non-HLA antibodies are persistent as pre-transplant levels in recipients showing graft rejection, but significantly decreased in post-transplant in recipient with functioning graft. So in conclusion, so several confounding variables such as previous transplant, gender, ethnicity, and primary diseases contributes to the variation of non-HLA antibodies. So the number of patients included in our studies are still, we are looking at over 1,000 patients, still it is insufficient to evaluate the impact of these confounding factors. Therefore, we need further systematic studies with multivariate analysis to determine the impact of non-HLA antibodies on transplant outcomes. So until then, we cannot use these non-HLA antibodies as a proper clinical testing. So this is my group. I will stop here. I'm not sure how to take the questions. Thank you.
Yeah, excellent talk, Dr. Rajalingam.
I don't hear anything.
One question. How do you treat a rejection with anti-angiotensin 2 receptor antibody, a strong antibody against anti-angiotensin 2? Dr. Rajalingam, how do you treat a rejection due to anti-angiotensin
Um,
2 antibody?
Vipul, any questions? I don't know how to handle this.
Type the question. We can.
I see Anil and Carmen from France. Hi, Carmen. I don't hear any questions. I cannot
Hello,
hear.
can you hear me?
No, I cannot hear. Oh, yeah. How do you treat a patient with strong AT1 receptors? Yeah, so people, I mean, they use the plasmapheresis and IVIG. That's what general treatment in our center. So the 81R, we tested only for the heart transplant program. We don't test it for the kidney. So they do the plasmapheresis and IVIG, and seems to be working. That's what they did. People, any other questions? I saw only one question. Okay, there's another question. When facing a ABMR in the absence of circulating DSA, if non-HLA MICA, how do you react? That is from Dr. Shruti. Yeah, so if you don't see a HLA DSA, but there is a ABMR defined by the biopsy, they test for all this available testing, particularly in our center, we do the endothelial cell cross-match, but they are not waiting for the report. They just start treating the patient with the plasmapheresis and IVIG. Because our report, the endothelial cell cross-match can be positive or negative. So if there's no HLA DSA, ABMR by biopsies, they treat with the patients. They don't. The non-HLA antibody testing is just collecting the data. It's not guiding the treatment. I hope I answered. Anil has a question. Our experience is that non-HLA antibody rejection respond to conventional ABMR treatment, but come back with a low-grade ongoing rejection and are very difficult to eradicate. I think I agree with you because there's no way to monitor whether this non-HLA antibodies are going down or up due to the treatment. Yeah, so I agree. So, without having a proper testing, monitoring the level of non-HLA antibodies, so it's difficult to adjust the treatment. Yeah, that's what my opinion, but my clinicians know better. So then we see some patients with another question. We see some patients with the full HLA match having ABMR in whom MICA is not positive. What is your observation? I don't believe MICA antibodies because it's a self antigen. It is expressed when the organ is exposed to the stress. So MICA antibodies again, another words, there's no quality controls and nothing. So, yeah, so when you have the full match HLA, then ABMR, it could be non-HLA antibodies, not necessarily MICA antibodies. Because when you say this full HLA match, is assuming the MICA also match. So MICA antibodies should not involve in the resection. Any more questions? That's good. The system seems to be working. Okay,
Thank you so much, Dr. Rajalingam. It was a very interesting talk, and we understand this subject in this area is growing. We all are learning, and maybe couple of years, in couple of years' time, we'll have good answers for this query, which is non-HLA antibody testing as well as the cause rejection. Thank you so much, Dr. Rajalingam, joining with us, and have a nice day. Shall we close the session?
Again, thank you very much, Dr. Shruti, for having me here. Again, I am missing in-person meeting. Thank you.
Thank you, sir. Thank you, chairpersons. This brings us to an end. This brings us to an end of the transplant immunology diagnostic session.
So I'll stop sharing.
So moving on to the next session, rejections. That's probably what we all fear the most. The science of rejection, with the first talk on acute rejections in transplant and management strategies. I'd like to call upon stage Dr. Bharat Shah, Director of Gleneagles Hospital, and Dr. Sharad Sheth to chair the session. Dr. Sharad Sheth is a consultant and head of Department of Nephrology from Kokilaben Dhirubhai Ambani Hospital and Medical Research Center.
I would request Dr. Carmen to start with a presentation. Can you hear us, Dr. Carmen?
Yes. And you? Can you hear me?
Yes, very well.
I will try to share my screen now.
Yes, please.
It doesn't work. Oh my God. To share the screen. It looks like, I don't know.
I can hear you.
Exactly. That I'm doing. Share only the presentation. Doesn't work.
That's okay now.
That's okay now?
Yeah.
Oh, great. And now it's okay? Now it's okay?
Yes, perfect.
So, great. Good afternoon, everyone. Thank you for your invitation. Hello from Paris. I'm Carmen Lefaucheur from Saint-Louis Hospital in Paris and medical director from Paris Institute for Transplantation and Organ Regeneration. First of all, I'd like to thank all of you for being here, wherever you are. still connected and interested by the proposal of the talk on the treatment of antibody-mediated rejection. So I will start by the starting point, what we want to achieve, what clinicians want to achieve by treating antibody-mediated rejection. Of course, we want the best choice for therapy based on mechanistic and clinical data. We want to be able to measure the response to our therapy, and of course, finally, improve the outcome for our patients. So what is the best choice for therapy? Excuse me, but I can't.
No, we are hearing you well.
Yes, but I can't move my slides.
No, your slide did move.
Okay. So what is the best choice for therapy in 2024? To address this point, we are facing a huge dichotomy. On the one hand, we made significant progress over the last 20 years in the understanding of the mechanisms of action of antibody-mediated rejection, and we have some strong candidates and immunotherapy candidates according to these mechanisms, some older, like the IVIG, some newer, like imlifidase or complement inhibitors, anti-C5 or anti-C1. And on the other hand, we have the reality of the fact that none of them is approved today by FDA or EMA in the treatment of antibody-mediated rejection. So why is it so difficult to define an ABMR treatment even in 2024? Some barriers are not specific for ABMR, are related to endpoints and FDA, to the industry, to the transplant community that is fragmented, all of us, because we still believe that our current outcomes in the field of kidney transplantation are great. However, we have also some specific difficulties related to antibody-mediated rejection to define the standard of care and the best therapy in the treatment of ABMR. And I will give you two examples. The first one is related to the heterogeneity of the phenotype of antibody-mediated rejection. And here you have the map, the picture of this heterogeneity of ABMR according the new classification, according BAF 2019 classification of humoral rejection. Here we have put it together in a prospective cohort, 881 kidney transplant recipients with a biopsy-proven antibody-mediated rejection. Is huge, is most 10-fold most kidney rejection cases that we have today in the literature, coming from 9 centers in Europe, North America, and South America. All cases diagnosed and reviewed according to the BAF 2019 classification. And as you can see, the ABMR is heterogeneous. We can talk about clinical, subclinical, active, chronic active ABMR, etc. On the other hand, we have also a huge heterogeneity of the treatment strategies in clinical practice. In the same cohort, we can see that only around 38% of cases were treated according plasma exchange and IVIG. Other associations were very frequent. So how to solve this dichotomy and how to move further? The key opinion leaders and the International Transplant Society have decided to make a recommendation and to solve this situation by making treatment recommendations in the field of antibody-mediated rejection. And I will like to highlight here three main points, three main progress that we made with this treatment recommendation. For the first time in this treatment recommendation made by TTS consensus, we connected the treatment to the phenotype of antibody-mediated rejection. And we make the understanding of the fact that all ABMR are not equal, and we have to consider the fact that the phenotype is related to time, time post-transplant, to DSA, to histology. The second main understanding coming from this consensus is the fact that, on the one hand, we can define today a standard of care, but this standard of care of treatment is not sufficient for every patient, and we have to consider sometimes for the beginning, sometimes at the end of the treatment, very early, adjunctive therapies, and these adjunctive therapies also are connected according to the phenotype of antibody-mediated rejection. And finally, the main point of and the peak of the iceberg in this consensus was that we were able to define a standard of care treatment in active antibody-mediated rejection represented by the Association of Plasma Exchange and IVIG. And here you have the reasons, the evidences on which the key opinion leader considered this association as a standard of care. The biological rationale, elements from supporting the benefit in clinical studies, international recommendation, including recommendation by FDA and KDIGO, the fact that even today the FDA use this association as standard of care in new clinical trial testing new agents, and is also the most used combination in clinical practice in different surveys and also in systematic reviews. So for sure, we made some progress by defining a standard of care, but we are aware about the fact that this association is and this standard of care we defined is mainly based on expert opinion, and most of the evidence is based on observational studies with heterogeneous population, heterogeneous diagnosis criteria, small clinical trials. So we are weak. We are weak, and we need, and there is an unmet need today for more evidence in the treatment studies for antibody-mediated rejection. The question is how to move forward. There are two possibilities. The first one, bring again a new study, a study in which we will compare standard of care to nothing or steroids. However, this classical and prototypical study, it was considered as non-ethical by all key opinion leaders in the TTS. So it's time to change and to move to next generation of clinical trials. And I will give you the example of such a new clinical trial that is a clinical trial emulation, a simulated clinical trial. To demonstrate the standard of care superiority, we performed in this prospective cohort of patients with antibody-mediated rejection, defined according Banff 2019, in a prospective cohort that was validated by EMA. So a well-defined, well-validated and registered by EMA. In this cohort of 881 kidney transplant recipients with biopsy-proven ABMR, we matched a patient one-to-one according using optimal propensity score matching, using 6 parameters that we consider determinants in the outcome of ABMR: the recipient age, the type of ABMR, the time from transplantation, the EGFR at the time of diagnosis, the level of DSA at the time of diagnosis, and the type of DSA, and also the scarcity score defined by IFTA. The endpoint was the graft survival at 5 years, and you have here for the first time the demonstration of the fact that what we name today the standard of care, the association of plasma exchange and IVIG, works better than steroid pulses and increase of standard maintenance immunosuppression. On the other hand, what you can observe here is that the standard of care works quite good in the first year or in the first 2 years after transplantation. However, the long-term graft survival after the treatment, the 5-year here graft survival, is poor, is still poor. So it's time now to move further and understand how to define very early the response to the treatment, predict outcome in order to define and to decide if the patient need or not other therapeutic strategies. In other words, we need to define the response to therapy. Regarding the response to therapy, if we have a look at the literature today, this is very poor. The evaluation of the response to treatment in a dynamic way before and after treatment is mainly made by the comparison, the changes between the level of DSA before and after treatment. Only very few studies used histology or, very surprisingly, the EGFR. But we are in 2024, and we made big progress, in the prediction system for risk of allograft loss in patients receiving kidney transplantation. And I'm talking here about the iBox that is today endorsed not only by scientific societies like the AST, ZOT, etc., but it's also endorsed by EMA and recognized as a surrogate endpoint for clinical trial. So we have today a solid and robust prediction system that could help us to move from the Kaplan-Meier curve, so from the population, the general population understanding and view on the graft, on the graft outcome, to the individual prediction of graft outcome in ABMR, because you have to talk as a clinician to each patient, and you have to decide for each patient if the treatment you give is a good one. So, individual prediction, what does it mean? So we can, by using iBox, we can have today the prediction of allograft loss at the time of diagnosis, and also very early at the end of the treatment. using this projection of the graft loss probability, we are able to measure and quantify exactly what is the benefit or not of such treatment in patients with ABMR. Here we have a very clear example. We're using the iBox for the evaluation of the treatment in routine today in my center. You have a patient with de novo DSA, a GFR that goes down, some proteinuria, DSA, and the biopsy that shows ABMR with glomerulitis, peritubular capillaritis, and C4D. The iBox, the prediction of iBox and graft survival at 1, 3, and 5 years looks like this: 79% at 1 year, 68 at 3 years, 55 at 5 years. So it's quite representative of what we have seen in the general population. So we have made the diagnosis, we have treated the patient, and at the end of the treatment, 3 months after the diagnosis, we performed another biopsy, and here we have the parameters, and perform also a new iBox evaluation, and this time we can see that the projection of the graft survival of the patient was clearly better, improved as compared with this made before at the time of diagnosis. And here you have this 92% of graft survival at 3 years, and in green the benefit between benefit in years of graft survival related to the treatment. Also, the TTS made recommendation regarding the ABMR monitoring. First of all, that the fact that the severity of ABMR should be evaluated at the time of diagnosis based not only on the clinical parameters but also on the pathology and anti-HLA phenotype. And maybe most importantly, the fact that we have to define the response to treatment, and this response to treatment should be evaluated not only by the kinetics of GFR that is used till today by the FDA as key and major endpoint in our clinical studies, and but also histology and anti-HLA DSA evolution and trends. Finally, how we can improve the outcome of ABMR that we still know that is not good enough. And I will give you two proposals. The first one, making the right diagnosis, and more than that, making the precise diagnosis. Making the right diagnosis today, it looks like easy in 2024. This thanks to the key role of the Banff classification and the standardization of the lesions and the classification. And today we all speak the same language that is good, but not good enough. Over the last years, we have developed a comprehensive Banff automation system for kidney allograft precision diagnosis that integrates all the rules of the classification. These rules were translated into a computer algorithm that covers all possibilities and scenarios of rejection. And we developed an automated computer assistant that makes accurate diagnosis by using these platforms and helps and assist the pathologist and the transplant physician for the diagnosis. And you will be surprised that even in 2024, 40% of our rejection diagnoses were corrected, reclassified by BANF automation, by the same classification we use in clinical practice. It looks like a ChatGPT BANF classification, automatized BANF classification helps the clinician and the pathologist to do the right diagnosis. And the right diagnosis implied the right treatment. And as you can see here in red, the 40% cases in which we misclassified the ABMR, these cases represent the patients with the poorest outcome. I said, make the right diagnosis. That is a first step, but also bringing more precision in our diagnosis is very important. And as you know, in BANF classification, we have today integrated new tools, and I'm talking about the molecular diagnosis by microarray or nanostring. That molecular diagnosis that can help us to reclassify histology in equivocal cases, subclinical rejection, non-specific rejection in cases with infection and rejection, and augmenting the histology by increasing precision and reproducibility, and also bringing some mechanistic insights. Again, an example, because I use it in real life today. We use today the nanostring in real life, especially in equivocal cases. And I will give you an example. Today, you have a patient in which we have de novo DSI, stable state function. The histology, no microcirculation inflammation, but isolated C4D. So you have 2 for the 3 elements to define an antibody-mediated rejection. Should we treat or not the patient? How you consider this patient, ABMR or not ABMR? Here you have, so we perform the nanostring evaluation, and here you have the projection of the gene expression around in the reference set according the nanostring evaluation. And as you can see, our patient is clearly projected in the group of patients with antibody-mediated rejection. And the results of the nanostring evaluation showed a high probability and also a high activity of humoral rejection. So we obtained and we have considered this third element for the diagnosis of ABMR according BANF classification. And we made the diagnosis of ABMR and treated the patient that, and today he has an excellent graft function. The second proposal to make and to improve our treatment and improve the outcome in ABMR patients is to personalize our therapeutic strategies. And when we are talking about personalization of therapeutic strategies, we have to integrate the role of biomarker, especially of pathogenesis-based biomarkers. Again, an example. over the last years, we made the demonstration of detrimental role of complement activating donor-specific antibodies. And more than that, we have made the demonstration that the persistence of complement activating donor-specific antibodies after the treatment is associated clearly with poor outcome. So my question is, should we wait 5 years to say, oh, my kidney or my allograft is lost to the, or should we intervene earlier? My answer is very clearly the second one, because we have today the demonstration of the benefit of using complement inhibitors, of course, not in all ABMR, but in patients with complement activating donor-specific antibodies with a specific effect in these patients. And based on that, the complement inhibitors were considered as a rescue therapy in patients with ABMR and complement activation, and are today reimbursed in France, not only in kidney but also in heart and lung patients with ABMR. Other situations, might be and other agents might be interested in the treatment of ABMR in rescue therapy. For example, the imlifidase. Of course, you all know here that the randomized clinical trial performed imlifidase versus standard of care was negative on the primary endpoint. Again, a negative study in the field of antibody-mediated rejection. And this was related to the heterogeneity of inclusion characteristics with a lot of mixed rejection, etc. That is not the point, but again, it's important to highlight this heterogeneity. Imlifidase, however, works well on cutting donor-specific antibodies, and we have the demonstration in desensitization. We have also the demonstration in cases with ABMR. Here we have an example, especially in patients with class 2 DSA, in which the plasma exchanges are not clearly sufficient or are not sufficient to clear the antibodies. I think we have all this experience that the TQ antibodies are more difficult to be cleared than class 1 antibodies. So here you have an example of using imlifidase in ABMR. Anti-IL-6 might be also a solution. Again, the study was negative, but we have this very strong issue in the field of ABMR to make and build positive studies in the field. But I'm still optimistic, and I will finish with this optimism. We have candidates. We have made progress, and we have a good understanding of the mechanisms. We have defined the primary targets, starting from DSA, plasma cells, B cells, NK, interleukin, complement, etc. There are phase 2 to phase 4 trials in progress, so it's for our duty today to transform the slippery slope into confusion in more successful randomized clinical trials in the field of antibody-mediated rejection by improving discrimination for prediction allograft survival, stratifying patients for the different treatment options ensure well-balanced arms in the clinical trial, integrate the disease process and the heterogeneity of the ABMR, and this is a way in which we will be able to make concrete progress. Thank you all for your attention, and I'm open to your questions.
Thank you, Dr. Carmen. Can you hear me?
Yes, very well.
Yeah, this is Dr. Bharat Shah. So that was an excellent talk. I have one question for you. At what stage of treatment of antibody-mediated rejection after treating with plasmapheresis, IVIG and rituximab will you decide to use imlifidase or tocilizumab?
For patients with that depends of some biomarkers, and the different biomarkers are the pathogenesis and the different markers of pathogenesis we observe in the biopsy by a molecular microscope, or also peripheric and circulating biomarkers, peripheral biomarkers, such as complement activating donor specific antibodies. So in a patient in which in the control biopsy after the treatment by standard of care, we still have complement activation gene expression or complement activating donor-specific antibodies, in these patients who use complement inhibitors. That could be Berinert, C1 inhibitor, that might be eculizumab or other forms of anti-C5, and there are many new candidates. Example, Sanofi study for using complement inhibitors. I think we have to make this progress. In other cases, we can have, for example, patients in which the nanostring show a lot of T activation that is associated with the T and B activation, and from these patients, it might be interesting to combine and to use thymoglobulin thymoglobulin associated with plasma exchange, etc. Sometimes, for example, for the big and oversaturated DQ, we can use imlifidase. So we have different options, but different options should, the option we have, all options we have should be defined this time on physiopathology arguments.
There's another question from Dr. Rajalingam. It's on the chat box, if you can read.
I can't see it. Maybe now, let's...
Or I can read for you. Imlifidase can reduce both CDC and ADCC, while complement inhibitors reduce only CDC. Can you comment on which one, imlifidase or complement inhibitors, is more efficient and cost effective?
The question is not, from my viewpoint, it's a very interesting question, but we have to consider the fact that the effect of imlifidase is reduced only to 5-7 days. Frequently, you have a rebound after. So, imlifidase is not the final solution. It's a solution in a very acute situation, and you have to combine it with other therapy that will help to diminish the level of antibodies and to control the rebound of antibodies. And among these elements, eculizumab might be part of the equation. So it's not imlifidase versus complement inhibitors, is how urgent we have to intervene. So if we are in a very, in general, if we have complement activation, the best solution, and as we have the recommendation by the TTS in early ABMR rejection with complement activation, etc., complement inhibitors are the first option. Sometimes we can have some huge forms, very expressive forms of rejection related to class 2, and the plasma exchange does not work, and maybe for just for few days it times the time to make some other treatment, you can use imlifidase. But today, this the place of imlifidase in the treatment of antibody-mediated rejection is not defined, is not well defined.
Thank you, Dr. Kamen. In the interest of time, we will have to move to the next session. And we would like you to continue. This is going to be a talk on thrombotic microangiopathy associated with blood group incompatible transplants. Let's move to the next one.
Yeah. Moving on to the next discussion on thrombotic microangiopathy in blood group incompatible transplants, I'd like to invite on stage Dr. Anup Chowdhury to chair the session. Dr. Anup Chowdhury is a consultant nephrologist from Nanavati Super Specialty Hospital, Mumbai. He has multiple publications in national and international journals. Requesting you to introduce the speaker, sir.
So, good evening. I think for today's speaker, there is no need of any introduction. Professor Dr. Tanabe is well known to all of us, and we see him as a man to go whenever there is any problem in ABO incompatible transplant. He is a director of robotic surgery, organ transplant center in Shonan General Hospital, and he received American Urological Association 1994 annual meeting award prize essay contest for honorable mention. So without wasting time, I would request Professor Tanabe to move on his topic, that is thrombotic microangiopathy in ABO incompatible transplants.
Thank you. Can you hear me?
Yes.
Okay, let's get started. Thank you very much to invite me to this very good meeting. And actually, yesterday I got a lot of the interesting discussions. So today's my talk is about thrombotic microangiopathy in ABO incompatible kidney transplant. I have no COI for this presentation. So nowadays, the ABO incompatible kidney transplantation in Japan is increasing. Almost 90 to 40% of living kidney transplantation in Japan is ABO incompatible kidney transplantation. Unfortunately, we don't have a paired kidney exchange program in Japan, so we need to overcome this kind of immunological barriers using the desensitization protocols. And actually, the long-term graft survival rate is almost the same as the compatible cases. And especially last decade, since 2005, we started to use the rituximab instead of the splenectomy. The outcome is almost identical between the ABO incompatible and the compatible cases. So let's talk about the causes of immediate post-transplant graft dysfunction in ABO incompatible kidney transplantation. Sometimes it looks like a very scary event. But for renal, maybe cardiac failure, volume depression, or hypertension.
Sir, Dr.
And-
Tanabe, your slides are not moving.
Oh, really? It's moving on my presentation.
Maybe stop presenting and start presenting again. Maybe it will.
Oh, sorry. I'm gonna go back. Now it's moving?
Yes, now it's moving.
It's not not moving?
Now it is not moving. I think in the presentation mode it is not moving.
Maybe for slide presentation doesn't work somehow. I'm gonna. Can you see my
Carry
presentation?
on in this mode only, I think. Yes, now
Okay,
it's moving.
all right.
Yes, yes.
So it's no animation stuff, so it's very difficult, sometimes difficult to see. But again, in Japan, we don't have any kidney exchange program, so we need to overcome the immunological barriers such as ABO incompatibility or HLA incompatibility. So nowadays, in Japan, the 30 to 40% of living kidney transplant is ABO incompatible kidney transplantation, and 20% HLA incompatible. So to do an ABO incompatible kidney transplantation is a very big impact to expand the donor pool in Japan. So here's a long-term graft survival of ABO compatible and incompatible kidney transplantation. Obviously, there is no differences even for a long term, because more than 20 years ago, we didn't have any TAC, we didn't have any Cellcept, but still the long-term graft survival is quite similar. And more recently, since 2005, the outcome is almost identical between ABO compatible and the incompatible kidney transplantation. So there are a lot of different causes of immediate post-transplant graft dysfunction. So today, most critical event is ABMR or TMA during the surgery or right after surgery. ABMR in ABO kidney transplant setting is not likely because anti-blood type antibody does not likely cause ABMR, because in most cases, blood antibody titers is not high, maybe up to 64 times in my times dilution in my institution. And also the anti-HLA antibody is already checked, and in most cases, it is reduced in low levels by desensitization protocols. And probably the TMA is the most likely the cause of acute dysfunction in the ABO kidney transplant setting. So most important issue is the TMA. The picture shows our case of TMA right after the revascularization. Revascularization, kidney become too pinkish, the good distension, start to make a urine, but maybe 15, 20 minutes later on, the kidney start to be very bad color and softened, and then finally it looks like this. So later I'm gonna describe, but surgeons always think about something wrong with the surgery, but it's not. This is, the well-known, the KD goes atypical hemolytic syndrome and the C3 glomerulopathy diagnostic flowchart. The TMA, first of all, you need to rule out the TTP and also the STEC, HUS, and then we finally get the post-transplant AHUS. So causes of TMA is, as you already know, needless to say this, but STEC HUS, TTP, atypical HUS, and the secondary TMA, which is a post-transplant TMA. So diagnosis criteria of AHUS is, the trias, hemolytic anemia, platelet count down, and AKI. stereotoxin negative, atorvastatin normal, and here the genetic abnormalities, acquired anti-CFH antibody negative. Secondary teams not always found genetic abnormalities. So atypical HS after kidney transplantation by recurrence or de novo. For recurrence, the complement factor H or factor I or C3 or complement factor I, which is very much often the recurrence. De novo one is a typical AHS. Today, I want to talk about mainly about this de novo AHS. So flowchart of diagnosis is the treatment option in the kidney transplant setting here. The TMA, of course, the STEC, the supportive treatment is a first choice. And if you see the TTP FFP infusion or plasma exchange. But the other atypical HUS, the HUS due to complement or coagulation disorders, the plasma exchange, but usually it doesn't work. And eculizumab, which is a C5 inhibitor, is very much effective. And secondary AHS should be treated by treat the original disease. But post-transplant TMA is very much complicated. It's classified in the secondary, but actually most of them are typical AHUS. So gene mutations AHUS, this is the data, Japan and overseas data. But in Japan, mostly the CFH, MPC, C3 mutations. I didn't have any experience with MPC, MCP, and the C3, but we have a couple of cases of the CFH mutations. And the risk factor of post-transplant TMA is back in 2001. It's a very small preliminary data, but at the time we had quite a lot of TMA, and we tried to analyze the data, and then we found that at the time, the ABO incompatible kidney transplant patient has a very high incidence of TMA, and also AHVL, which is now it's a antibody-mediated rejection. If the patient has this, 100% of patients get a TMA. The TMA negative group showed a very low incidence of ABO incompatibility and antibody-mediated rejection. So at the time, we thought somehow incompatibility or maybe rejection, antibody-mediated rejection could be a risk factor for a TMA. And also we looked at the TAC trough levels. And at the time, the very beginning of the clinical trial of the tacrolimus, and we set up the trough levels with very high levels, very high, 20 to 18 for both groups. And nowadays it's about 10. So it's almost double. So even though the very high levels, we didn't see any differences between two groups. And this is just a small summary. We had 24 TMA at the time, and the 11 cases were ABOI. The 13 cases were ABO compatible. So the ABOI case is a very high incidence of TMA compared to the compatible case, almost 2.5 times more TMA after transplantation. So pathophysiology and also how to treat the TMA. The stage one target events for kidney transplant, maybe ischemia or drug or rejection, and then stimulation of the vascular endothelium, and then the thrombi microvasculatures, and destroy RBC and overactivation of the complement. At the time, the genetic abnormalities in complement regulation factors, then it causes a vicious cycle. But and then the clinical manifestation of the HUS. So we need to cut this cycle, otherwise we cannot stop the atypical HS after transplantation. So eculizumab only the treatment option for TMA at this moment. The classical component pathway in acute AMR in the sensitized kidney transplant. But that same situation, the eculizumab blocked the C5 activation to a C9. So I'm going to show the two cases, a couple cases of the TMA, experience. The 30 years old male, primary disease HUS, actually sick, the diagnosis. The patient, 22 years old age at the time, had a diarrhea, bloody stool, followed by macrohematuria, and resulted in chronic renal failure in 2 months. And renal biopsy showed the TMA. And the clinical diagnosis was STEC HUS from their clinical manifestation. But actually, they couldn't get sugar toxin positivity. So we thought this is the STEC, even though there's sugar toxin, but the clinical manifestation is a very typical manifestation. So we scheduled living kidney transplantation from his mother, and back in 2010, almost 15 years ago. And I blood type compatible and no immunological risk, and we just induction therapy with the basiliximab. And after treatment, after transplantation, 2 weeks after transplant, protocol biopsies was no rejection. And after that, the creatinine gradually increased. So we performed the 4-course biopsy 3 weeks after transplantation. Serum creatinine level was 2.0, and the biopsy showed a TMA. So we are very much surprised why we have a TMA. So we thought that could be some kind of genetic mutation. At that time, we didn't have any eculizumab, so just repeat the plasma exchange. And finally, we found the CFH mutations. And fortunately, at the time, we called the Alexion company in the United States. They generously provided the eculizumab clinical trial for free. So we gave him the eculizumab 90 milligram per body twice a month, and the kidney function stabilized. This is a 4-course biopsy 3 weeks after transplantation, thrombotic microangiopathy, typical findings, and 2 months after transplant, chronic phase of thrombotic microangiopathy. And almost 9 months after surgery, the chronic phase of the after the TMA. So IFD is progressing. And now, but the patient is undergoing eculizumab 900 milligram injection twice a week, and almost 15 years after transplantation. But his serum creatinine level 2.1 with a stable condition, and she got married and had a baby at the time. So I'm going to show the 2 cases of the severe HUS, the 2 cases here. First one, the 68-year-old male, primary disease was unknown. And it was a blood type B antibody incompatible kidney transplantation. Baseline titer was 128, not high, and immunological risk is low. And actually, I showed the picture, but the Doppler ultrasound renal got 3 hours after reperfusion. It was so bad. It looks like a renal artery stenosis. At the time we performed the biopsy, it was a horrible biopsy specimen, like here, and the C4D here. So at the time, the pathological diagnosis was hyperacute rejection, TMA glomerular arterial capillaries, and the tuberitis, capillaritis, and the arteritis are very mild, not so bad. And C4D staining PTCs, of course. So about 2013 at the time, V1, G1, PTC all 1. It's not bad. So, so we decided to give him the clinical HS strongly suggested. So we gave him the plasma exchange, but didn't work. So eculizumab was given at 6 POT. Actually, you can see here, maybe you can see here, but we didn't do we did the plasma exchange at the time, but not for the ABMR. And the antibody titer, it was 2 times dilution, which is very, very low. And after that, the eculizumab injection 2 times, and then the clinically the kidney functions improved. Then at the time, we didn't know what's happening on, so we gave the IVIG for the patient also. And this is a Doppler linear allograft 1 day before and 1 day after first dose of eculizumab. You can see the big differences. So 3 weeks after transplant, we performed the focus biopsy, transplant glomerulopathy state of after TMA, acute anti-active antibody mediated rejection. But again, it's very mild. So we think this is not primarily the ABML, because some mild ABML, but main event is a TMA. And after the rituximab injection, C5b9 was gone. So second case is a very young lady, lupus nephritis, and antibody titer was only 4 times, 64 times, very, very low levels. Currently, we don't do any plasma exchange for this kind of patients. Immunological no risk, but after the surgery, the clinical HUS strongly suspected. So PEX 1 2 didn't work. So we gave her the eculizumab, and immediately it's recovered from the this condition, and the kidney function improved. The post-operative 2 weeks after surgery, left-hand side on the table, back table, biopsy specimen. Actually, the TMA here. So genetic analysis we did for case 1 and case 2. Case 1 has some mutations in CHF and the CFB, and the case 2 has some mutation in CFH and the THBD, but both are likely to be a kind of polymorphism, not a genetic mutation for the complement activation. So most of the time, we cannot find any definitive genetic mutation in the TMA cases after transplantation. So it's very much likely the typical genetic mutation related HUS after the transplantation. Most of them are kind of atypical HUS, maybe caused by some ischemia, some kind of not severe, but kind of rejection, or maybe some prolonged ischemia time or something like that. So how to diagnose and treat a post-trans TMA? The quick diagnosis TMA is ruled out of ABML. If it's an ABML, we need to focus on the ABML treatment more intensively. But immediate treatment by eculizumab is very important. The worst scenario is I show the picture, but the surgeons may want to do reoperation, reanastomosis, renal artery for just in case. But this is not right choice. This procedure makes the TMA situation worsen because of ischemic injury with the complement activation more and more. So post-transplant AHUS, again, the CFH, CFI or CFB is very likely to recurrence. So maybe we need to continue the treatment. But other than that, the third atypical HUS, we don't need to continue. Actually, now we have more than 10 cases of atypical HUS after transplantation without this kind of without any mutations. For those patients, a couple of times of the eculizumab injection is good enough to control. And prophylactic injection of the eculizumab for the typical genetic mutation HUS patient is very much effective. So this is the take-home messages. Immediate post-transplant graft dysfunction is ABOI is serious and a critical event, and most of them are post-transplant TMA, maybe with some ABMR. But ABO incompatible is one of the risk factors for post-transplant TMA, and the rapid diagnosis and the rescue injection of anti-C5 monoclonal antibody is highly recommended. Even though the ABMR combination, the C5 inhibitors is very effective. So now I didn't mention today for that time, but we developed the C5 short interference RNA already. It's really, really effective to control the this kind of C5 activation. Could be used for prophylactic treatment for TMA or ABMR in ABOI or HLA-I recipient in the near future. Reoperation is re-anastomosis of the renal artery is the worst choice in TMA after ABO incompatible kidney transplant. Thank you very much for attention. I'm happy to have a question.
Thank you. Nice presentation. I would like to invite questions from the floor. Yeah.
Professor Tanabe, Dr. Bharatcha here.
Hi.
Hi. Sorry for the problem we faced yesterday, but today it went well.
No problem.
Now
I got a discussion. Yes.
Now my question is that if you have a TMA after ABO incompatible transplant and you treat with eculizumab, how long do you need to treat?
Yes, it's a very good question. Many people think about that point. The CFH or the obvious genetic mutation patient, I think they need a long time for maybe the permanent treatment for for prevention of the TMA, AHUS. Otherwise, once they got some kind of the infections, they may have HUS. But the atypical HS type, like no genetic mutations, we don't know why it's happening. But we have a lot of patients after ABO incompatible kidney transplantation. So ABO incompatible kidney transplantation always C4D positive. That means somehow the components are already activated. So in that situation, we give the eculizumab a couple of times, but you don't need to give them the long time because after the transplantation, most of the patients in the rituximab era, for the anti-blood type antibodies, almost zero or sometimes deleted under very low levels. So I don't need, most of the cases, you don't need to continue for a long time.
There is another question I'll read for you. It is in the chat box. Is there any difference? Can you read that? Is it there in your chat box?
Sorry, I can't see that.
You can't read. Okay, I'll read for you. Is there any difference in severity of rejection, whether it is anti-A antibody mediated or anti-B antibody mediated?
It's also a very good question, but we did not examine that question point. But it seems to be, for my experience, it looks like the same, but AB incompatible, AB, both, AB2O, something like that. it looks like more severe than the other A or B incompatible cases. So maybe differences of the antigens more and more, it seems to be more severe.
Okay, okay. Any question from the audience? Yeah, one question.
What is your current incidence of the TMA in your ABO incompatible? Is it still around 10% or is it lower now?
It's something like 2 to 3%, less than 5%, I think. And a compatible cases currently no TMA, because the year of 2000, 25 years ago, we had a lot of TMA, but at the time, the treatment of the immunosuppression was not so good as now. But now we can screen the HLA incompatible patients, but 25 years ago, no single antigen method or no, just a cross match. So now it's more and more we treat the patient with a very much selected patient.
So usually CNI tacrolimus use is associated with increased incidence of TMA.
No, I don't think so.
Okay.
I don't think so. You know, even though the 25 years ago we used a huge amount of tacrolimus, but TMA patient and non-TMA patient, same trough levels. And now we don't see any that kind of stuff.
So we don't need to reduce the dose of tacrolimus in ABO incompatible.
No.
Okay.
But again, our experience, the induction phase, the trough level is about 10. So it's not high again, and so you don't need to change.
Okay, thank you.
Well, if there are no more questions, thank you, Dr. Tanabe, for a wonderful talk as usual.
Thank you very much.
Thank you.
Have a good meeting.
So, Professor Tanabe, if you could stay online, we have next talk by Professor Anil Chandrekar.
Mm-hmm. Sure, yes, I would.
Hi, how are you? Good to see you again.
Good to see you, Anil.
Yeah. Okay, so let me see if I can share my screen here. Let's see. Share presentation.
Dr. Suratkar and Dr. Bhavikar, two senior transplant physicians, we would like to invite you on stage to chair the session.
Can you see my screen?
Yeah, it's well seen.
You can see my slides?
Yes. Put it on presentation mode.
Presenter mode? How's that?
Yeah, perfect.
Okay. Shall I begin or?
Let me introduce Dr. Anil Chandrekar to this audience. He is a medical director of kidney and pancreas transplant in Brigham and Women's Hospital, Harvard Medical School. He is a past president of American Society of Transplantation, past director, Transplantation Research Center in Harvard Medical School. Over 200 original articles, review articles, and book chapters, 10,000 citations of original research and articles, contributing author to multiple textbooks, including Harrison's Textbook of Medicine, Brainer and Rector's, the Kidney, the AST Primer and NKF Primer. His research interests are translational research, regulatory T cells, BK nephropathy, novel immunosuppressive strategies, and hyperlipidemia. So, stage is yours, sir. So, please go ahead with your talk.
Thank you very much. Thanks for that introduction. I'd like to thank the organizers for inviting me. I know I'm the only thing that is standing between you and dinner, so I'll try to be as brief as I can be. And, you know, I have actually moved. I'm no longer at the Brigham and Women's Hospital. I've moved to UMass Chan Medical School at the beginning of the year, where I'm chief of nephrology. But I still have collaborations at Harvard Medical School for research. So, as you already heard this evening about antibody-mediated rejection, it remains a very challenging area to diagnose and to treat. So, treatment of chronic management is even harder. So we'll go over some of the basics, and some of this is repetitive, but I'd like to really give you sort of more of a personal view of how do I deal with this based on my own experiences. So treatment of AMR, how is AMR diagnosed? Are all cases of AMR the same? So you already heard that there's a great degree of heterogeneity in terms of AMR, and that in itself is a problem, because that would indicate that there are probably different strategies for treating AMR in a more personalized way. And if you cannot diagnose it uniformly, then how do you treat it? And the second point is, at what point in the development of immune response are you seeing the antibody-mediated rejection? And we'll come to that in a moment. So then we'll discuss what are the principles of treatment of AMR and how do we know that we've treated AMR? So successful treatment of AMR, why are there barriers to this? Well, first of all, diagnosis is complicated, as we've heard. You know, biopsies, you cannot biopsy the patient continuously. There is differences in the reads of biopsies. And biopsy is essentially giving you a histological diagnosis, and it really doesn't necessarily speak to the underlying mechanisms of what's going on and causing the AMR. There's no unequivocal standard of treatment, as you heard before. Both the American Society of Transplantation and the TTS have worked on consensus conferences, but there isn't really an unequivocal standard, and everybody may be doing similar things, but nobody's doing it exactly the same. Treatment is expensive. A lot of the drugs that you heard about in the last few talks are very expensive, and treatment is complicated. And there's a great potential for over-immunosuppression of the patient. And we don't know when we should stop treating the patient. That's another potential problem. So one of the ironies is that the incidence of antibody-mediated rejection has decreased, right? So we have become more acutely aware of antibody-mediated rejection, and the number of patients that we see with antibody-mediated rejection within the first year is significantly down. So it's estimated to be between 3 to 10% incidence in the first year. At our center, it's less than 5%. And but antibody-mediated rejection does, of course, portend a worse prognosis. This is the latest, or this is a recent data from the SRTR, which shows, regardless of the type of induction therapy, whether it's anti-IL-2 receptor antibodies or cytotoxic, anti-thymoglobulin or no agents, the percent of rejection within the first year is very low. So one of the truisms about antibody-mediated rejection is that there always has to have been some degree of T-cell involvement in developing an antibody-mediated rejection. The question is whether that T-cell rejection is still ongoing or whether it's in the distant past and you have an autonomous state where antibodies are being produced and attacking the transplant. So this is a cartoon of the way that we understand how an antibody response is actually developed. You need to have, first of all, interaction of a naive T cell with an antigen presenting cell, and then there's activation of a T cell, which then in itself activates B cells to produce antibodies. And at some point, these B cells become memory B cells and then plasma cells, and are producing antibodies autonomous of the T cell. So the T cell then has no ability to control that antibody production. So one of the questions is, where are we starting? Are we starting right at the beginning where the antigen is being presented? Or are we starting later on when donor-specific antibodies are detected and the process has moved on to an autonomous state. And that is one of the difficulties in both selecting the right treatment and also understanding where we should, how we should treat the patient. Now, you can start with this response before transplantation, and you have patients who are, of course, pre-sensitized, and they are on the right, where they have donor-specific antibodies. And I would say that applies to patients who may have had antibodies in the past, but currently don't have any donor-specific antibodies. Maybe historically they have had, because that indicates that they've had a memory response and they can jump to producing antibodies very quickly. And this is really the talk in a nutshell. So if you are talking about management, if you're talking about early on and the ongoing developing antibody-mediated rejection, which may be concurrent with some indication of T-cell rejection, then you need to make sure the patient has adequate immunosuppression to prevent this from starting in the first place. If this is ongoing and is still in process, then the strategy is really aggressive treatment, and we'll talk about some of the immunosuppressive medications that can be used. But then when you get to a certain stage, I would say that when you have antibodies and you have all of the active T-cell rejection has burnt out and you're left with something like transplant glomerulopathy, which is still antibody-mediated rejection, and you have glomerulosclerosis and more of a chronic injury picture, really the best that we can do is conventional CKD therapy targeted at preserving GFR, using ACE inhibitors, and nowadays talking more about spironolactone or more novel mineralocorticoid receptor antagonists, maybe SGLT2 inhibitors will play a role in the future. The problem is, of course, by this stage you have low GFR, and it becomes more challenging to know if these therapies will be effective. So we'll quickly go over the diagnosis of AMR. I think you all know this, and I'm not going to spend too much time. Part of this is really just to indicate that 10 years ago, when we used to get histology back from transplant biopsies, it would say T-cell mediated rejection or antibody mediated rejection. I rarely, if ever, see a biopsy that is read as antibody-mediated rejection. Is now nearly always read as chronic active antibody-mediated rejection. And that may be because there's more awareness that there's some ongoing inflammation that's contributing to that, or T-cell mediated response. But this shift in how we are classifying these rejections also has implications for how we treat the patients. And again, this is premature. I don't need to go through this, but these are part of the diagnosis of antibody-mediated rejection, which I'll skip because of time. The other point I wanted to make, and I'm sure you understand this very well from the talk prior and you heard today, is that there's a central feature of endothelial injury within the microvasculature. This is really important because at some point you've tipped over into a scenario where this is a chronic injury that cannot really be reversed by active treatment. And this injury to the microvasculature is then the most profound type of injury that you're dealing with. So how do we conventionally treat antibody-mediated rejection? Again, you heard earlier today, this is the conventional treatment that I'm sure you're all familiar with. It's, most people will go with plasmapheresis, intravenous immunoglobulin. The protocols differ as to when, how often you do this, when do you give this, how much do you give. Then people may add some B-cell depleting therapies, such as rituximab. If there's any evidence of T-cell injury, you may give steroids or anti-thymocyte globulin. And then people would consider complement inhibition or proteasome inhibition and potentially modification of maintenance immunosuppression. This is the Cincinnati protocol, which is the one that we used to use at the Brigham as our standard treatment for antibody-mediated rejection. If this does not succeed, then we would think about using an anti-complement inhibitor. And I'll show you some of the data on that. Having said that, most of these treatments are not super effective. If you really think about how is it that an antibody rejection is created, as I said before, what is really critical is the interaction of the T cell with the B cell. So you can imagine if you have a therapeutic that is targeting that interaction or is influencing that in a major way or is hitting both T cells and B cells, that is more likely to be effective. So even to this day, and even though it's not on the slide, one of the most effective therapies for antibody-mediated rejection is cyclophosphamide. Of course, we don't use it because of its toxicity. But of the modern drugs that are being used, I would suggest that the one that shows the most promise is actually belatacept or CTLA-4 Ig. And the reason for that, I suspect, is because it is targeting the T-cell, B-cell interaction. The other reason, of course, maybe that is often used as a substitute for tacrolimus. And the non-specific injury that is associated with tacrolimus, which also affects the endothelium, may be playing a part in shortening survival of grafts in patients diagnosed with chronic antibody-mediated rejection. And there have been a number of studies which have shown that the likelihood of having anti-donor HLA antibodies in patients treated with belatacept seems to be lower than with conventional immunosuppression. This is a list of agents that have been looked at. It's not comprehensive. It's a little bit out of date. I would say that there is no evidence that really any of them has worked very effectively for chronic antibody-mediated rejection. So now I will give you a couple of examples, and some of you may have heard these examples before, but I think they illustrate the point. And first I'm going to talk about the highly sensitized face transplant that we treated. And why am I talking about a face transplant patient here? Well, the reason is that this gives us an insight and gives us an ability to look at histology on a continuous basis. In other words, you cannot biopsy a kidney every day, but you can biopsy a face transplant every day if you need to. And so it gives us a much more, it gives us an ongoing way to measure our response. And this is the face transplant patient that we transplanted who was highly sensitized, whose PRA was 97%, and who also had donor-specific antibodies at the time of transplant, and both flow positive and cytotoxic, mild. You can't really say cytotoxic cross-match is mild, but it's also positive. So the principles for treatment for this patient, this is somebody who is known to have preformed antibodies, is transplanted and develops acute antibody-mediated rejection immediately. So the principles for treatment for this was to remove the circulating antibody effect, reduce the antibody production, to target T cells, which were still playing an active role in the antibody-mediated response, and reduce inflammation, and therefore theoretically target the cells that would be expressing the target antigens, the HLA, and the endothelial cells. And so with this treatment plan, we made sure that at every single day, the patient was receiving a medication that was targeting all four of these areas. Even though we had to switch them out, sometimes we used plasmapheresis, sometimes we used complement inhibition. And we treated the patient in an ongoing way, essentially for 2 months. And what happened is that we were successful in treating the patient, and although she developed severe acute antibody-mediated rejection, what you can see on the right is the decrease in the antibodies over time as we continued to treat her. And it took really about 4 months before we got the rejection under control, but by 4 months, there was no evidence of cellular antibody-mediated rejection. And then over time, what we saw was that the patient remained quiescent, but then at certain time points developed these episodes of rejection, which were mostly C4D positive and antibody mediated. But over time, the other thing that you saw, and this is a pyramid with the oldest time points on the bottom and the newest on the top, is that the number of antibodies, anti-HLA antibodies that she had circulating went down. And most of the time she was negative or had one non-donor specific antibody. The ones in red are donor specific antibodies, the ones in black are non-donor specific. So over time, this went down. Despite this, you can see on the left-hand side that she had episodes of antibody-mediated rejection. And eventually, she lost the transplant. Basically, the face transplant was lost. And what she had was this, it looked like sclerosis of the face. She got a new transplant, luckily, but basically all of the vessels and the arteries had this vasculopathy, similar to what you see in chronic antibody-mediated rejection in kidneys and actually in other organs as well. And so she actually lost her face transplant, but then was retransplanted, which was almost a perfect match and continues to do well. So one of the things I would point out is that we tried to measure her immune response during this process because one of the things we were very concerned about was, are we over-immunosuppressing the patient? And although there are no really good ways to measure immune function, we used the Silex assay or the immunoassay, which is non-specific stimulation of circulating T cells. And basically, if you have a low response to non-specific stimulation, then you are more likely to be over-immunosuppressed. And as you can see from this graph, that most of the time she was over-immunosuppressed, and sometimes very over-immunosuppressed with very, very low lymphocyte response to antigen. So despite this, she was having ongoing episodes of antibody-mediated rejection, which were independent of her ability to mount a T cell response. So that sort of very clearly demonstrates this division of an ongoing antibody response to an allograft, which is independent of your ability to immunosuppress this patient. The second case I'll present is the case of a young boy who's 13 years old, 2 previous transplants, very highly sensitized, and wanted a 3rd transplant. So in that last case with the face transplant, I talked about treatment at the time of transplant starting, when there's a preformed antibody at the time of transplant going forward. In this case, we wanted to desensitize this child so that they could receive a deceased donor transplant. So desensitization for living donation has been well described, but how do you do it for deceased donation? So this is, again, a child who had calculated PRA in the 90s. His cytotoxic T cell PRA was 77%. And what we did was we pheresed him continuously. And this just indicates the decrease in the cytotoxic T cell PRA from the time of treatment. He also had rituximab. And what you can see after a couple of rounds of pheresis, his anti-HLA antibody response dropped and remained, around 50%. And you can see on there, was pheresed 35 times, 3 times a week, at the same time as being dialyzed. A very tough regimen for this kid. Now, at the time of transplant, his cytotoxic T cell cross-match was negative, but his flow cross-match was extremely positive. So that was positive not just to, in the neat serum, but also in the diluted serum. And not just for one, but actually for multiple donor-specific antibodies. So this is the kind of cross-match you would get, and you say, there's no way we're going to transplant this individual. Cytotoxic was negative. It had been positive, it turned negative from the pheresis, which dissociated the ability for the antibody to fix complement. So we did this, he was transplanted. 12 years later, his creatinine is 1.2, and he's double the size, so his creatinine is obviously higher. Never had rejection. There was a biopsy done 13 months after transplant, which really showed no specific evidence of rejection. And here we got campath induction therapy and is maintained on sirolimus and azathioprine. So what those two cases illustrate to me is that even with fairly conventional therapy, you can treat antibody-mediated rejection if you have the fortitude. If you and the patient are willing to go through what it takes to get on top of the rejection, you can actually treat it. Now, even if you treat it, as in the first case, it doesn't prevent injury to the graft, because some of this, it goes beyond immunological injury. It is the sequelae of having immunological injury. In the second case, when you really remove the immunological response or you nullify it at the time of transplant, there is an opportunity for you to be able to control the antibody response. So he still had antibodies post-transplant that were circulating, but never had antibody-mediated rejection. I would suggest it's because his endothelium, the endothelium of the graft healed, and the target for the antigens was probably decreased, and the expression of the HLA on the endothelium was probably down. So very quickly, just to illustrate some of the other novel immunosuppressive agents that are used, we did a study for antibody-mediated rejection using eculizumab, comparing it to conventional therapy. And essentially, it's a multi-center study. What we showed was that eculizumab was fairly effective at reducing antibody-mediated rejection, but then it would come back as soon as we stopped the treatment. And this is a patient, as you can see, had multiple rounds of treatment with eculizumab, but these are the protocol biopsies that they had at each time point. We never really got on top of antibody-mediated rejection, and they developed, transplant glomerulopathy and always had chronic active antibody-mediated rejection. So the complement inhibitor works. When you stop using it, it stops working. We've already talked about imlifidase today. As you may know, that multi-center study that's been used, as Dr. Carmen had suggested, was not actually successful, even though it reduced the antibody, circulating antibodies in the short term. In the long term, antibodies came back, and patients, not surprisingly, continued with antibody-mediated rejection. Same with anti-IL-6, although it shows promise in chronic active antibody-mediated rejection, it hasn't really been successful. So in summary, I would say there's no standard for treatment of antibody-mediated rejection. Therapy needs to be aggressive, and it needs to treat all aspects of injury, meaning if there's a T-cell response, you've got to treat that. You've got to make sure that inflammation is reduced in the graft as well. And failure is often related to tolerance of treatment for the patient or the physician, as it is related to efficacy failure. And this is a slide I'm just presenting again for you here as a summary. And with that, I'm happy to take questions. Thank you very much.
Thank you, Dr. Chandragar. It's always a pleasure to listen to you. And if there are any questions from the audience.
Can you read the question?
The question from Dr. Rajalingam is, there was a strong preformed BW4 DSA, which is known to be highly detrimental. This could have been avoided by selecting a BW4 negative donor. Can you comment on why HLA compatibility was not assessed for this face transplant?
So the face transplant patient, face transplant's not like kidney transplant. There are not that many donors. And this patient had already waited, I think, 4 times as long as any other face transplant that we did. So we were really concerned that we would not be able to get a compatible donor. So we decided that we would do that. So, we didn't have the luxury of waiting for a donor that would be negative to everything.
So what is the protocol in your center about treatment of chronic ABMR?
So chronic ABMR, basically what we do is we use conventional therapy, plasmapheresis, IVIG, bortezomib, plus or minus rituximab. And we treat the patient, rebiopsy, treat the patient, rebiopsy, until we have either evidence of efficacy failure, if they're not responding at all to that, then we say that's really it. There's nothing much more that we can do. We may sometimes consider complement inhibition, but again, my experience has been that it works on a very temporary basis, and there isn't really appetite to do this in the long term. If there is evidence of if there's evidence of response to treatment, and you end up with more of a chronic injury as opposed to active immune response, then we utilize spironolactone, and ACE inhibitors and other therapies to reduce the proteinuria to really see. And I think that is effective to a certain degree. We have a number of patients who have low-grade ongoing antibody-mediated rejection, meaning transplant glomerulopathy and positive DSA, who we have maintained the allografts for some time with just aggressive conventional CKD therapy.
Anil, you said that in every antibody-mediated rejection, T cell also has a role. So, would you consider treating with thymoglobulin in addition to conventional ABMR treatment?
So we do when we think that T cell always has a role. The question is, does it have a role now, or has it had a role, a year ago when in developing the antibody response? So if it's just what we would consider a pure antibody-mediated rejection, then we wouldn't do that. But nearly, I would say, 70-80% of the time, you'll see some degree of T cell injury, even if it's just very sort of generalized tubulitis. And we always treat with steroids. We give a significant amount of steroids at the time, and we would give thymoglobulin if it was more significant, T cell mediated rejection. And then ultimately, and I should have said that to the answer to the last question, when we don't succeed with plasmapheresis and IVIG, we use Campath. And I will give half dose of Campath, and then potentially give them another half dose later on. And we found that to be somewhat effective in some of these resistant cases, but it's a difficult drug to use in patients who've been immunosuppressed already.
You also mentioned in the beginning about use of mineralocorticoid receptor antagonist in chronic antibody-mediated rejection. What would you prefer, the new non-steroidal drug Kerendia or our standard spironolactone?
So I've been always used spironolactone for decades in these patients. We're starting to use some of the newer agents, and we're seeing how well they work. But spironolactone, it works to some degree, particularly if it's more a transplant glomerulopathy that you see than anything else. So yes, my experience has been with spironolactone. And I find, and I start patients on a very low dose of spironolactone, maybe 6.25 and then 12.5 daily. And then, I find in many cases they respond to that.
Any other question?
Or at least it helps.
Any other question from the audience? Well, Anil, thank you so much. That was a very nice presentation, and look forward to having you each time in our transplant immunology meeting that we have.
My pleasure.
Thank
All right. Thank you very much.
Thanks.
Enjoy your dinner.
Yeah, thanks.
Bye-bye.
Thanks.
minimization and steroid avoidance trials. He had once come to University Health Network for grand rounds, and he presented all his work. But the last slide was, I would not do steroid avoidance, because in doing steroid avoidance, you would end up giving more steroids later on. So he said steroid minimization is a better way to go ahead rather than avoidance. So coming from the horse's mouth that he did the trials, but he doesn't agree with it.
So minimization.
Yeah, minimization, but again, let's see what.
Just a quick point on the persistent infection that you were talking about. Many times these are not persistent infections, these are recurrent infections. So I would dig deep into the water, the fruits, the veggies, how are they getting cleaned, how are they getting processed, what kind of water, RO
That is
testing.
taken care of. A detailed history has gone. I have sat with them and it's all done.
So-
Everything is
so
RO
those-
and all that. Yes,
so-
I have
so
sat
those
with
would be-
them. Yeah.
those would be-
Even the fruits and vegetables all are really in boiling water. They are really clean. But one biopsy which was done through the colonoscopy, it showed none of these things. Crypt wasn't there, cryptosporidium. And cryptosporidium should come up on the stool biofire, no? If it's not coming up, biopsies.
In children, you don't use thymo?
Because it
thymo
has-
should have been the
That's what I'm
induction
thinking now. I
agent.
should do as the next as ATG.
No, I think
We avoid using
Sir
such-
was saying, no, we use a lot of thymoglobulin and steroid free for children. All children will be steroid free by rule. Even if you do an ABO incompatible in children, that will also be steroid free. And we have done ABO incompatible, probably the first ABO incompatible with steroid free.
And your steroids are stopped by 5 days or
5
first
days,
week?
5 days
Okay.
stop, yeah.
Fine. Great. Thank you.
So if there are no more questions, thank you, Dr. Manoj, for an excellent talk.
Thank you, sir, and thank you, chairpersons. Moving on to the last session, CMV and solid organ transplantation, bench to bedside. I'd like to invite on stage Dr. Wasim Kot as the chairperson. He's a senior consultant, infectious diseases from Gleneagles Hospital, Mumbai. He has an antimicrobial stewardship, hospital infection control, transplant ID, and HIV are his areas of interest. Multiple publications and various book chapters. I'd like the chairperson to introduce the speaker.
It gives me great pleasure to introduce Dr. Mayur Ramesh. He's a consultant medicine and infectious disease at Henry Ford Hospital, Detroit. He has several publications in international journals. At Henry Ford Hospital, he leads as Medical Director, Clinical Trials Office, Medical Director, Translational and Clinical Research Center and System Biorepository. He is a leader for ID research and Senior Staff Physician, ID, Transplant and Immunocompromised Hosts. And he will be talking on CMV. Over to you, sir.
Yep. Thank you to the organizers. I hope you can hear me. I'm just going to go to the presentation mode. I have no conflict of interest, and today we're going to talk briefly about CME and SOT as an overview. Then, based on timing, we will talk a little bit about resistant and refractory CMV and risk factors associated with resistant refractory CME and SOT, and some management strategies. So if you look at CMV seroprevalence in the United States, it's at least 50%, and it's higher with age. But when it comes to developing countries or other countries such as India, for example, we have a much higher seroprevalence. And as we know, the latent CME genome can be present in many nucleated cells in the body. We'll start with the case. A 65-year-old man, bilateral lung transplant for pulmonary fibrosis, a CMV primary mismatch, D plus R negative, immune suppression is tacrolimus, MMF, and prednisone. How do we prevent CMV infection and disease? So as you know, in CMV and SOT, in sort of primary mismatches and stuff, we tend to get the higher risk seem to be more with lung and heart-lung transplant. probably directly related to the degree of immune suppression used in lung transplantation. And then comes the pancreas or kidney pancreas transplantation. And pancreas by nature is also immunogenic. In kidney itself, it's about 30%. Liver comes next and heart is the least. As you all are very well aware, the risk factor stratification is based on donor and recipient serology and CMV IgG, and the lower risk is D minus R minus, and the intermediate risk is any R plus, and the high risk is D plus R minus. So in the past, we know that serology is only for risk stratification. Culture is not routine use for clinical purposes. It takes a lot of time. Histopathology is for tissue invasive disease. Occasionally, we find an isolated GI disease where you get tissue invasive CMV without any viremia. Antigen assay, the PP65 is not used anymore, and we have moved on to molecular assay routine, and it's standardized across the globe. So when you look at CMV molecular assay, it's a quantitative nucleic acid testing by real-time PCR for viral load, and it's very sensitive and specific. Until recently, it was not very well standardized, and there was significant viral load variation between labs because there was no, and plus there was no universal viral thresholds. And but all of this became a little bit more concordant with the availability of international standards. So what is the utility of viral load monitoring? It definitely correlates with severity of infection disease. Higher the viral load, higher the severe the infection. It definitely guides preemptive therapy, sensitive and early detection of viral replication, prognosis of disease severity by monitoring absolute viral load and trends in viral kinetics. And obviously, can be rapidly, it helps with rapid diagnosis, and you can correlate the duration of treatment and risk of relapse with viral load. So there are several commercial assays. The original one was Roche, and now we have Abbott and several other assays that have used the standardized platform. So in the past, before the standardization, particularly in the lower end of the spectrum, you can clearly see there's a lot of inter-lab variability when CME results were reported as copies per ml. So the QNAT standardization happened through WHO standard using a Merlin strain and US standard using a Town strain. And so once you use the standardization, now you convert your copies. So now any laboratory, like local laboratory tests, can also use the same as long as you standardize against these standards and report the results as IU per ml. So as there are, these are some of the sort of classic assays, the Roche one and the Abbott one, which can go even to a very lower level of detection. And once it's standardized and reports as IU per ml. And you can clearly see even the laboratory standardized test along with the, for example, in this case, Roche assay, you can clearly see that in varying titers, there is concordance. And when they did multiple labs at this point using the international standardization using IU per ml, you can, there is inter-laboratory quantitative agreement with standard assay. There is still some issues in lower end, but it's much better than pre-standardization. So going to CMV management strategy, you could do preemptive therapy or prophylactic therapy. Preemptive therapy is where you monitor CMV once a week in asymptomatic patients for at least 12 weeks following transplantation, and you treat with antiviral therapy once the QNAT is positive for CMV replication, and patient is still asymptomatic at this point. Prophylaxis is where you start giving it soon after transplantation, antiviral prophylaxis, and then switch to antiviral treatment in case there is CMV viremia or disease. So as you very well know, there is significant consequence of CME in solid organ transplant, such as high risk for complications, tissue invasive disease, opportunistic infection like co-infections like viral and fungal. There is a high risk of post-transplant lymphoma, PTLD, and a high risk of graft rejection and increased mortality. So moving back to the case, The patient was initiated on valganciclovir 900 milligrams daily, with, and the EGFR is greater than 60, stopped in 2 months due to leukopenia, and 2 months later presents with diarrhea and diagnosed with CME colitis. And the plasma CME DNA viral load was 270,000 international units per ml. And patient was admitted for IV ganciclovir. So what are the management drugs that we have? We have IV ganciclovir, we have oral valganciclovir, and we know now that in moderate viremias and moderate disease, that valganciclovir is still as good as IV ganciclovir. In severe disease, we still rely on IV ganciclovir for better bioavailability. And then as we go into more and more refractory or resistant CMV, we move on to foscarnet or cidofovir. Obviously, they have significant side effects. I mean, recently, for kidney transplants, letermovir, in addition to hematopoietic stem cell transplant for prophylaxis, letermovir was approved for CMV, and maribavir is approved for adult and pediatric patients with post-transplant CMV infection and disease that is refractory. Refractory treatment with or without genotypic resistance. And there are several targets for these agents, like ganciclovir UL97, and in addition to UL54, and similarly for scarnet and cidofovir have UL54. Letermovir UL56, maribavir is also a different UL97. So those are some of these targets. So going into ganciclovir, valganciclovir, obviously the IV form is given for significant severe disease, life-threatening disease with a very high viral load, or when patients have questionable GI absorption. And generally not recommended to co-administer with letermovir, valacyclovir or acyclovir. And you do weekly monitoring of PCR along with serum creatinine and complete blood count, because the side effect is myelotoxicity. And you give until the viral load is negative for at least 2 weeks. So you check once a week, and you want below the threshold of detection, you want it before. So that's how you manage your treatment. And then based on your immune suppression, you make a decision whether you go to secondary prophylaxis with valganciclovir or other alternative agents if needed, or just monitoring from there on, depending on where your immune status is. So clearly, the common side effect is cytopenia, and as clearly shown here, that there is significant leukopenia. The longer you use, the higher the leukopenia. And so following up on the case, the CMV viral load continues to rise above 1 million over the next 3 weeks. Immune suppression is decreased. A patient was switched to IV foscarnet due to concern for resistance. They checked serum IgG levels, and it was greater than 500. So no IVIG was given. Serum genotype showed no ganciclovir resistance, so which is definitely possible because the patient is immune suppressed, and immune suppression reduction was not significant enough in this situation. Why? Because the key for management of CMV, the first key is still immune suppression reduction, and the second is an appropriate antiviral agent. And the patient was switched back to IV ganciclovir with improvement of viral load. So when do you test for resistance? So when do you suspect? You suspect for ganciclovir, you need to be at least have had a 6 weeks exposure or longer, and at least 2 weeks of ongoing full therapy with appropriate dosing. And what do you test for? You test for UL97 and UL54 gene for mutations, and there are several well-known canonical mutations, and UL54 mutations as well. So after 7 weeks, the CME viral load starts to rise again. Absolute lymphocyte count is low. Repeat CME genotype shows UL97 mutation, as you can see, L595S, and UL54 did not show any mutation for ganciclovir, foscarnet, or cidofovir. So one of these 7 UL97 mutation is this mutation, and this detected in greater than 80% of the cases with ganciclovir resistance. So the definitions for refractory CMV is basically, if it is possible, it's persistent viral load at least 2 weeks after appropriate dose therapy, and and definite refractory CMV is CMV viremia that increases at least 2 weeks of appropriately dosed antiviral therapy. So the first probable is persistent, refractory is increased. It continues to get worsened, and probable is lack of improvement of end organ disease, is lack of improvement in the signs and symptoms after at least 2 weeks of appropriate therapy, and refractory CMV end organ disease is worsening in the signs and symptoms of end organ disease after appropriately 2 weeks dose therapy. So and why do you and how do we know it is refractory disease? You need at least greater than 1 log in blood or serum after 2 weeks of appropriate therapy, and you test for viral resistance at this time. So what are the potential risk factors? Are prolonged antiviral therapy, prior antiviral exposure, recurrent infection, poor drug absorption, so suboptimal drug delivery to the body in the setting of CMV viremia, and obviously the type of transplant like we talked earlier, and the overall net state of immune suppression. So the same thing is depicted here from host status. D plus R minus is a higher risk, and lung transplant is a higher risk, prolonged antiviral exposure, and subtherapeutic drug levels. So a systemic review of 86 observation studies in US and Europe in SOT and HCT showed that refractory CME can be up to 21% and HCT even higher. Resistant CME up to 14% and HCT is 19%. So the prior algorithm for refractory resistant CMV was a little bit complicated with the presence of significant resistant testing, and then going into stating when do we do foscarnet and Cidofovir, very toxic drugs. So things were not very clear. And I would encourage all of the people to use this clinical decision support tool for CMV. It's very useful. It guides you in an appropriate manner. So the current approach recommended by the various societies of American Society or Transplant Society for refractory resistant CME management is when you have active disease. If it's mild, you go to oral valganciclovir. If it's severe, you go to IV ganciclovir. Of course, you can get cytopenia, and you may need granulocyte growth factors at this point of time. And when you do not tolerate the first-line agent or resistant to first-line agent, the prior second-line therapy was foscarnet, and the third therapy was IV Cidofovir. But now, with the advent of maribavir, we move straight to maribavir from IV ganciclovir. If we cannot tolerate or resistant to first-line agents, we go, instead of going into foscarnet and Cidofovir, we have the option of going into oral maribavir, at least in the United States. So we could do high-dose ganciclovir in selected patients, and the dose escalation can be from 7.5 to 10 milligram per kilogram to 12 hours. But obviously, the cytopenia becomes much more significant in that setting. And what about foscarnet? And clearly, the message from this slide is that based on studies which are not like formal randomized studies, many anecdotal experiences and other observation reports, you can see that there is 31% CME relapse, about 66% virologic clearance, 51% renal dysfunction, and a 31% one-year mortality. And with Cidofovir, it's particularly similar, particularly it tends to cause a significant renal disease as well. So both these agents are not ideal when it comes to things, and then comes maribavir. And maribavir, as I said, it acts on UL97 as slightly different than ganciclovir at this point. So the large Solstice trial for refractory CME infections with and without resistance post-transplantation is what we'll discuss briefly. So it's a phase 3 trial, and the primary endpoint was a confirmation of clearance of plasma CMV DNA at the end of the therapy. And secondary endpoint was CME viral clearance and CME disease symptoms at week 8 and maintenance through week 16. So the message was Maribavir did better than investigator allowed therapy in a statistically significant manner. And there are several subgroup analysis. The transplant type mattered, and the responders seem to do a little bit better with solid organ transplant compared to hematopoietic stem cell transplant. With genotypic resistance, there is some variation that you can see here. And baseline viral load. So this is very important when it comes to Maribavir, that if your viral load is very high, you're not going to respond. Maribavir is not your drug. So if your viral load is average, then you can use Maribavir. And similarly, there were improvements in secondary endpoints. So what do we know about Maribavir? Maribavir targets only CMV, so we do need additional VZV prophylaxis or HSV prophylaxis using acyclovir. So clearly, if you have the treatment effect was lower in subjects with significant refractory CMV and higher viral load, it does not work. There is, but so far there's not been a major mortality benefit documented, and there is cross resistance to ganciclovir and valganciclovir to a certain degree. Relapse can still be observed with Maribavir. And letermovir, which originally approved as prophylactic agent for allogeneic stem cell transplant. Recently, the phase 3 trial was completed for kidney transplant. It's now approved for kidney transplant as well as prophylaxis. But it also does not have activity against other herpes viruses. So when you give prophylaxis with letermovir, you are required to give prophylaxis for HSV with acyclovir or valacyclovir. There is minimal drug interactions, but the most important thing is you do not want to use this as treatment necessarily because of low genetic barrier to resistance. So you want to remember that. And there are certain other medications available that people have tried. Obviously, switching to mTOR inhibitors compared to, say, purine analogs tends to help with CME management. People have tried leflunomide, artesunate, and in pretty significant severe diseases, people have tried monoclonal or polyclonal CME antibodies or CME cytotoxic T lymphocytes. CME vaccines are still a moving target. People are trying, and we are working with several CME vaccines that hopefully will come to market in the near future as pre-transplant prevention. So in this patient was started on Maribavir 400 milligram twice a day. Viral load became undetectable. Switched to letermovir, secondary prophylaxis 480 milligram along with acyclovir 800 milligram twice a day. Tacrolimus levels need to be monitored with letermovir, and we need to consider reducing statin. And it was stopped after improvement of the overall absolute lymphocyte count over time. So if you look at challenges, side effects, for example, for safety, ganciclovir, valganciclovir is bone marrow toxicity. For Foscarnet, cidofovir is kidney toxicity. Maribavir, the only side effect is altered taste. Otherwise, it's pretty benign medication at this point of time. And letermovir, rather than some drug interactions, it's really also benign, like with tacro drug interactions. And I won't go through this. So conclusion. So we talked briefly about approach to CMV. Definitions of refractory resistant CMV are now established. And there's a concern for resistance. You need to quickly check for genotypic assays for viral mutations, UL9754, and now we have UL56 and for letermovir as well available. Please use the CDST for management strategy. It's a very useful online tool. Maribavir is an important addition to the management of refractory CMV, and we can avoid toxic drugs like Foscarnet, cidofovir, and letermovir may be used as prophylaxis. So thank you very much, and I'll wait for any questions.
Thank you very much, Dr. Mayur Ramesh, for such a wonderful talk on CMV, the role of transplant. Before we open the question to the audience, I had a couple of questions. One was, what is your CMV preventive protocol for small bowel transplant, do we use initial IV till the mucosal integrity is established, and do you use immunoglobulins as prophylaxis? And second question was for of CMV and rejection. How do you, what has been your experience of CMV and managing rejection?
Okay. The first question is on small bowel transplants or multivisceral transplants. How do we manage? Obviously, there is no standardized study on this kind of stuff. It's anecdotal experience from people. And there's a lot of significant immune suppression use, routine use of thymoglobulin, routine use of rituxan, and all those things are done very early in the game. So the patient is significantly immunosuppressed. So we do prophylaxis, and as long as the patient is tolerating their immune suppression orally, then we use valganciclovir orally. So we are not afraid to use valganciclovir necessarily, because you can use your tacro level as a surrogate marker to say that, yep, you're absorbing your medication, and you can definitely switch from IB-GAN to oral valganciclovir. The only headache is how long to treat. We do treat them, prophylax them for use prophylaxis for a much longer period of time because of the over-immune suppression, and until the next state of immune suppression becomes decent. On the second question of resistance, second question of rejection and CMV. So we take this approach, this one. So I didn't talk much because of the short times they're given to me. I didn't talk about establishing a threshold. So in our center, even though we have standardized CMV viral testing, it's still essential that you establish thresholds for various different transplants, whether it's hematopoietic stem cell transplants or solid organ transplants of various kinds. We establish a threshold. For our center, this is based on pre-post, and we created a threshold, pre-post studying of new testing methodologies, and based on that, our threshold we have established, for example, in renal transplant, in our center, once again, it's for our center here, is 1,000 IUs per ml. So the viral load is below 1,000, and it's sort of lingering below 1,000. The only thing we may do is may consider reducing immunosuppression a tiny bit. So we avoid rejection in that setting. But if the viral load starts going above 1,000 and it's persistent, that's when we intervene with an antiviral agent as a treatment modality. So we don't allow a CMV to go significantly higher to cause rejection as CME consequent rejection at this point in time. But in a setting where patient is already rejecting, and because of high use of immune suppression, CME gets reactivated, that's a tough problem, because then you are just relying on your antiviral agent to treat, and you're not relying on your immune status to help the CME virus at that point of time. We do the best we can.
Thank you, sir. Any questions from the audience?
Yeah, I had a question. I had two questions basically. First is for compartmentalized disease, for example, CMV colitis, where you may not have a CMV PCR to follow. How long do you treat? And second is, what is your threshold for starting patients on secondary CMV prophylaxis? Because a lot of times patients will not have recurrence. So when do you think of starting secondary CMV prophylaxis?
And so so I'll sort of do a caveat. See, in India, you have the advantage because of seropositivity is higher in the population. It's probably well into the 90s in India, whereas we still have primary mismatch in a lot of our patients, decent number. 55% is what we have as seropositive as the prevalence. So going back to I'm sorry, I'm blanking out on the question. Can you quickly tell me the question? I'm sorry, I got distracted.
Compartmentalized disease, how do you follow up on
compartmentalized disease. Let me finish that first. The compartmentalized disease on GI disease is difficult, right? In about 15% or so of patients who will have localized GI disease, colitis, diarrhea, and symptoms, where only a biopsy has proven it, and you don't have viremia to go by, what do? You don't want to keep doing colonoscopy again and again to do this. So on an average, we tend to do about 6 weeks of therapy and look for clinical symptom improvement before we consider any sort of secondary prophylaxis. So next, then the question of secondary prophylaxis as in CMV as an overall management strategy is very, it's a tricky question because you cannot do universal secondary prophylaxis on anybody. So I work with my transplanters significantly. I ask them, okay, where was your immune suppression before? Where is your immune suppression now? And what is your anticipated immune suppression? Obviously, as you all know, in transplant, we don't have a test to measure immune suppression, right? We don't have a tool to measure immune suppression. Net state of immune suppression, we cannot measure. Even tests like immuno and all those things and stuff that are very average. So we don't have a clinical standardized way of measuring T cell suppression, for example. So all we have is arbitrary way of managing immune suppression by experience or population-based evidence, like saying that, okay, within 3 months, we need the ATAC level to be here and this one to be there and that kind of stuff. So we don't have a consistent, this one. When it comes to a patient level, it's very difficult. So I rely on my transplanters to tell me, okay, I'm anticipating in this patient, I'm happy to keep the immune suppression at this level. I'm not going to increase further, or the increase is very minimal, then I may avoid a secondary prophylaxis completely. It doesn't mean that we have to do universal secondary prophylaxis just because CMV was reactivated. So it's a combined decision that we work with the kidney transplanters because they tell me this one, and with experience, we try to adjust accordingly. I mean, obviously, we tend to monitor for CME in such setting, so we do preemptive monitoring in that setting, if such is the case, so that we, at least for the next month or two, to make sure that the CME doesn't come back.
Any more questions? Once again, thank you very much, sir, for enlightening us on this important topic.
Thanks very much. Thank you.
So this brings us to the end of TIS SOTI 2024. Over the last 3 days, through shared knowledge, collaboration, and exchange of ideas, we have achieved our goal of simplifying the concepts of transplant immunology and infections, and also paved the way for improved patient outcomes. To all the speakers and presenters, your profound knowledge and insights have been invaluable. To all the delegates, your presence and active participation has enhanced our knowledge. Thank you for taking the time out of your busy schedules and being here with us. Let us continue our shared journey towards a future where every transplant patient receives the best possible care. See you in TIS SOTI 2025. The dates will be announced soon. A small reminder to all the delegates and the faculty to please collect your certificates at the registration desk. We have a Google feedback form. Please take out a few minutes and let us know so that we can improvise and make it even better next year. Thank you from the organizing team of TIS SOTI 2024.